public meeting of Kettering General Hospital Board. I don't have any apologies today. I am welcoming, or will welcome in due course, Emma Wimpris, who's head of volunteering across the group, and Mara Tonks will be, who you mostly know from Kettering, who's also in Northampton now, who will be talking to us for item 11. And we have Karen Spellman, who I'm beginning to stop mentioning as an invitee because she's here so often. She might as well take up residence, really. Good morning, Karen. Do we have any other apologies that I've missed, Richard or Richard? No? Okay, thank you. If you'd like to go straight into the patient story, please. I think that's Faye and Fiona. There's a theme to today's meeting, or there is a sort of a theme around discharge and around flow. And this one is kind of the start of it. We had a similar theme in Northampton yesterday, and we had some pretty good conversations about this as a major feature, if you like, a major focus of where we should be looking at around quality and performance. So, patient story, a discharge program. Fiona, over to you, please.
Thank you, Chair. So good morning, everybody. I would like to introduce James Gillespie-Allen, who's our Head of Patient Experience, who has kindly undertaken the patient story with the support of Kieran, who's going to be playing the relevant video. Thank you, James.
Thank you. For those of you who have not met or are joining from outside the organisation, I'm James, Head of Patient Experience and Involvement here at Kettering Hospital. We have a patient story for you today, linking, as Alan has said, to the agenda around discharge. And the story you're going to hear begins with a negative experience and ends on a much more positive note. The patient describes her experience with communication from our teams and also her experience around discharge, as I've mentioned. As always with these stories, her words explain it better than I ever can. So I'd like to hand over to our IT colleagues to play the video for you.
I was first admitted to HC Pretty Ward on the 23rd of December and then moved to Poplar Ward on the 28th, where I was discharged on December the 29th. I returned home with my usual carer support in place. I fell in the bathroom on the 30th of December and didn't have my phone or lifeline, which meant I was on the floor for around 16 hours until my sister found me when she was delivering groceries. An ambulance was called and I was taken back to A&E, but there really was a long wait. I was so tired I just slept. From here I was admitted to Thomas More Ward on the 31st of December. I was told that as I had been readmitted within a short time, this was called a failed discharge. The difference I received in care was remarkable. While on HC Pretty Ward, the attitude of certain staff members was appalling. They just didn't want to know and came across as if they didn't care, and there were long delays in answering the call bell and they never seemed to be in any hurry. I understand that there are staff shortages and there are some very challenging patients on the Pretty Wards, but I feel that they took it out on the patients. When I was moved to Poplar Ward, this was totally different and the staff couldn't do enough for you. My only concern is that I think I was sent home when I wasn't ready. I hadn't been on my feet in a while and my muscles were weak. I think this is why I fell. Thomas More Ward staff had a totally different attitude. They couldn't do enough for you and they were always cheerful. There was a 90-year-old lady in the next bed to me. She was very worried about going home. They talked to her and just really cared for her and took time to wash her hair for her. Just a very different experience. Whatever they could do for you, they would. The communication was good on the ward, and when planning discharge, there were 2 rehab options. Once this was decided, things moved quickly. It would have been good to have a bit more notice so it didn't feel too rushed at the end.
Thank you. So you've heard about some of the communication issues that have been raised specifically around attitude and talking to the patient about discharge and making sure that they feel ready to go home. So this has been escalated to the divisional director, and we are in the process of booking time with the ward to share this story with them specifically in their ward meetings, because we know the impact that these stories can have when you hear it from the patient themselves. Regarding the first discharge, To offer you reassurance, all of the assessments that were required took place and demonstrated that the patient was able to mobilise with an aid and appropriate care arrangements in place, which were arranged for her leaving again. However, she did sustain another fall and was readmitted back to hospital. The lead nurse for the area is in contact with the patient and is talking through with her the concerns in more detail to understand the different elements of them, and to look at what lessons that we can take from that and moving forward, and will feed into some of the further work that I know that Fiona is going to talk about later on in today's agenda. Any questions at all?
Any comments or questions on that? Debbie.
Thanks, Chair, and thanks, James, for sharing that story. I know that the particular patient didn't want to appear on camera, but I'm very thankful to her for sharing that story, and really sorry to hear that she didn't have a particularly good time on HC Pretty wards. Communication's key, isn't it, to whatever we do in healthcare day to day, and we do hear this on occasions that we don't get it right all of the time. So I'm really pleased that we are hearing from Fiona later on around complaints. With regards to discharge, again, communication right from day one is so important so that we can get it right for when the patient does actually leave hospital, and that they feel well enough and safe enough to leave. And of course, it is our job to make sure that we are providing on discharge the right care in the community, and that balance is quite difficult on occasions. And again, through the agenda we'll hear more about this around discharge and some of the challenges that we face and the actions that we're putting in place. Because the hospital is busy, the whole NHS is busy at the moment, so it is a really fine balance between making sure that we're not keeping people in for too long and obviously discharging them when they need to go. So just a thank you really, and look forward to hearing about discharge and the rest of the agenda.
Okay, Alice, then Janet, please.
Thank you. I very much wanted to make the reflection about communication that stuck out for me, that it seemed a rush at the end. And I think that's in common with a lot of our patients, that they don't hear anything about it until they're leaving in 5 minutes. And I think that doesn't allow people to get their head in the right place for that being a comfortable process. So that shone out for me. I think the other reflection or question back to the exec, I guess, would be, how can our experience be so incredibly different on a potentially quite similar wards in some senses? And what does that tell us about what was the real recipe for things being successful, or the recipe for things not going so well?
Yeah. Janet. You're muted.
No, it took me a while to get the button there. Sorry, Chair. So for me, there's a question really, what, as non-executives, we could look at how we could support and consider, and the point that Alice made about potentially the issues on each of the ward. We're hearing a lot about absence rates in the organisation at the moment. So potentially there's something there about how we offer support and training. So I'm pleased to hear that the ward is having a conversation, but I would imagine in order to motivate and keep morale up, it's important that we as non-executives from a board perspective are able to be more visible now as we're moving forward. Thank you.
Trevor, and then Faye.
Thank you. I just want to first of all reflect the communications point, but on 2 points in there. One was the readmission in the term, the failed discharge, and whether or not we have any fast track processes to bring people back into the organisation without having to go through a long wait in A&E. Query, there may have been a break or something like that, somebody's fallen, but could we not look at that? And the second one is, there's been no comment on communications with friends, family, carers, etc., and where they sit in this, both this case but more widely, in terms of often the complaints on the discharge is about them not being in the loop just as much as the patient themselves feel that they are rushed into the discharge. Thank you.
Okay, yeah, let's gathered a few of those comments, and between Faye and Fiona, I'm sure we'll get some sort of response. Faye.
Yes, thank you, Chair. So yes, just wanted to comment in some of the work that we are doing in terms of patients that are readmitted within a matter of days. We are absolutely validating those patients to see if there's any learning. And some of the work that I'll talk about later is some of the work we're doing around board rounds and making sure that we are talking to patients right at the outset about their discharge and their family, just picking up on Trevor's point. But we actually have a steering group where we review all of the discharges that are come back into the organisation, as I say, to make sure that we are learning from those patient experiences, to see if there is anything that we could have done differently. Thank you.
Fiona.
Thank you, Chair. Can I thank each of Alice, Janet and Trevor for your comments? I think it's really helpful to have that feedback. This is a difficult story, a disappointing story to listen to, and as James has rightly said, when you hear it from the patient themselves, it's so much more powerful. And I think the key message here is around communication. That's the thread between the initial failed discharge and the success, the positive communication that we've received on 2 other wards. In regards to Pretty's ward in particular, the focus is going to be understanding what the issues were in regards to the communication, because communication is such a wide a topic area to address. And when I talk a little bit later on the agenda about our complaints and the work that we're doing, I'll be able to go into a little bit more detail about how we're focusing on that. But I also recognise Janet's points about having visibility, both as a senior team from a nursing and allied health professionals perspective, a senior team as in the executive team, and the opportunity for our non-execs who during March have started to come back into the organisation, which is really appreciated. And I think Trevor's point in regards to the communication with the carers and the relatives and families, that's key as part of our future patient experience improvement work. And I can pick that up a little bit later. Thank you.
Lisa, and then Rabia, please.
Yeah, I'd really like us, if we could, to come back to the point I think Alice was trying to make as well, because we're making a lot about the process in terms of the communication and the discharge process. And I think the way I understood Alice's question was, is there actually an underlying cultural difference within the wards? And whether or not we can respond to it here or we need to take that away, but I think that's an important point to come back to.
Yeah. Janet then, and then Rabia.
Thank you. I'd just like to say, from a communication point of view, if I understood it correctly, this isn't going to be shared with the ward until after we've heard it today. And I just wonder whether from a compassionate perspective and from a caring approach, that it wouldn't have been better to take it to the ward team from a learning point of view, first of all. That's just a reflection. Thank you.
Okay, thinking about that. Let's go Rabia, Fiona, Simon.
Thank you, Chair. And just really a difficult one to hear, but thanks to Annie for sharing it, and thank you for everybody for their comments. I wanted to come back to Trevor's very valid comment around is there anything we can do to make readmissions of such cases better, or at least the communication better. And what I want to say is one of the things we are working on with regards to discharges is making sure in discharge planning, the information which is given to patient, there is a dedicated, committed person and the lead that they can contact rather than having to come through ED. So a nominated consultant can be contacted back, and that actually do 2 things. One is to cut that in between ED, but also it may be that all the patient needs is an advice rather than readmission. So that certainly is helping at Trevor, but that's one of the things we're doing. And the other point, which I think few of us have raised, is around the culture. So what we've now started doing is working and looking at it as teams. So the group, Faye had mentioned, the steering group and the other discharge planning groups. Now we've got junior doctors and other staff groups in it as well, to see how things can be worked better as teams. And very valid point from Janet. And I think that's something we definitely need to take forward, that it should be discussed with the team as well prior to anything else. So thank you for that.
Okay, final comments, hopefully picking up the points. So Fiona and then Simon.
Thank you, Chair. So I think it's very right of Lisa to raise the concerns around the culture within the wards and the potential differences between the wards. Until we've undertaken a little bit more of a deep dive into the actual situation and those staff caring for Annie, it's difficult to surmise at this point what those themes will be, but that's a process that the team will be going through. And I recognise Janet rightly pointed out the timeliness of sharing the story. When James, I appreciate James may still be on the line, when James was able to meet up with Annie, this was shared when he came back from that meeting with the senior team within the division straight away, so that we can start to address those concerns that have been raised. Thank you, Chair.
Simon. You're muted, Simon.
Apologies, on an iPad today. To your question first, Alice, wards differ in the quality of their leadership. We know that, and I think one of the things that we now need to do coming out of COVID, and linking the point that you made about disability, Janet, I would suggest, Alan, that we bring back through committees and to board at a kind of assessment of how is our ward leadership now doing? Where do we think we need to support people? Where do we have examples of excellence? Because as we will hear later on in our private board, there are examples of excellence that have also happened over this period of time. And I think particularly the other point I'd make is that my observation would be the key thing around excellence is how do we make it consistent? So I think both in the space of where do we think our ward leadership is, and looking at that systematically again, and how consistent is that ward leadership, I think we should bring that back into discussion. And I think Annie's story rightly challenges us to do that. On a macro level point, one of the reasons why discharges fail, however, and personally the other thing I find difficult in listening to that story at a personal level is for a patient to be labelled as a failed discharge seems to me to be a wholly pejorative conversation that we need to move away from in the way that we organise discharge. But it was the point around organising discharge that I wanted to make. I would expect the ICB fairly early on to be considering a proposal to radically reshape how we deliver Pathway 1, Pathway 2 and Pathway 3 care. One of the reasons why discharges do go wrong is because our discharge system into the community is now so hugely fragmented with so many providers involved. Just the simple transactional chances of things going wrong. And there's a whole other side to Annie's story about how did she end up in a bathroom falling over without a lifeline that we haven't yet explored. But I think one of the things that we will need to do as a system is start to reorganise the way we provide discharge and how it is organised. That doesn't take away from the points that are made about leadership. That's our bag, our responsibility. But we need to do better on that other arc of the story as well.
Chris.
Thank you, Alan. I agree entirely with the cultural issues, but let's just focus on the local culture. There is a national culture here. I've been researching the concept of right to reside in a ward. And as far as I can see, there is no research or clinical basis for this diktat that's been put out recently. So right to reside colours the whole issue of patients being got out as quickly as possible.
Yeah. As we go through today, you'll see some of the causes and complications around this. And clearly, nobody's targeting a zero readmission rate. That's too risk averse. You're looking at a low percentage readmission rate as being reasonable. I do take the point about failed discharge as a very pejorative term, and it's blindingly obvious, isn't it? If you've got 20 odd wards in Kettering, their quality of leadership will form a normal distribution curve, and it's very difficult if somebody says to a board that we have a discharge planning problem in Kettering Hospital. It's much more sortable if you say to the board, we have a discharge planning problem in Pretty A ward. So it is about focus and about precision in this. So I take your point, Simon. I think we should come back. We should look at this, do an assessment of ward leadership and the next level up. After all, it's their responsibility too. But I also recognise the points being made, and more generally, both in our system around ICANN, which talks a lot about reason to reside, and nationally. And ICANN should be a major player in offering alternatives for this lady in the first place, about her home care and so on. So there's a lot of issues running around here. So let's not lose this one. Let's think of a way to bring it back in due course, and thinking about it in the round rather than just what Pretty did wrong and what Thomas Moore did right. Anyway, we'll come back to that. We'll come back to that in a way that between Fiona and Debbie and Simon, you think is reasonable. Okay, thank you very much. Thank you, and thank you to our patient. You can't get better unless you get told about things in the hospital. Minutes of the meeting on the 31st of January. Are you happy that they are a fair record of the meeting? Yeah, good. And the action log, there's nothing any outstanding there. So you're happy with that. Okay. Chair's report. Well, we set our board agenda a bit ahead of 5 or 6 days. So it was a bit prescient when we were called to a mandatory meeting, regional meeting, and it's a series of national meetings, really, where the leadership of the NHS was particularly agitated about ambulance waiting times. And they made the point that the category 1 response times were not being met nationally by about 30 or 40% in terms of time, but the category 2 response times were not being met by about 400% in terms of time. And they were particularly concerned about this. And that gave rise to a conversation that said that boards must discuss this whole issue, but ICB boards must discuss it as well, because it is a system problem, as evidenced by the previous video. It is about flow, it is about alternatives for patients, it is about ambulances not being the first point of call necessarily for all sorts of things. It's about SIS 111 and so on. So, so having the discharge stuff on today seemed remarkably appropriate. Now, Kettering's figures are pretty good, as Faye would no doubt leap up and tell me, around ambulance handover times and so on. But I think you have to see this in the context of the stuff that came out yesterday around national patient survey, national patient satisfaction with the NHS, which is the lowest it's been. I thought some of the answers were a bit contradictory, but the basic proposition that the public don't think we're doing very well is evidenced mostly, apparently, around lack of access to GPs, which is not our territory, but also elective waiting lists and queues in ED. seem to be major factors in that decision. And of course, as a publicly funded service, it's hard to survive without public support. So it's very important that all these things come together. And certainly the top of the NHS, and presumably their ministerial leaders, are particularly agitated about the high risk that follows from ambulance handover delays and therefore ambulance response times. So that's that. The only other thing I wanted to say is we have the first meeting of the ICB Integrated Care Board in shadow form, at least, later in April, after its delayed implementation to July. So it will be meeting in shadow form, and I have pressed hard for a major part of that conversation to be about the success and the readiness of ICANN to deliver, because that underpins the entire planning structure that we have around patient numbers, around activity, around what we can do for our waiting list elective patients, because we need the space freed up from our so-called stranded and super stranded patients. So all of that becomes a theme going through this, and it will play out into the plan, the plan for the coming year, which we have to submit at the end of next month, which John and others will be talking about. John and Karen will be talking about in both the public session and the private session. So that underpinning of it all by the ICANN thread becomes very important as well. So just wanted to give you a sense of the pressure the service was under, and the fact that the discharge theme is probably the single biggest metric, the single biggest measure around how successful we're going to be in the coming year or two compared to all the other things. So just keep that thought as we go through it. The only other thing to mention from my point of view is, of course, Ockenden 2 was published yesterday. It's on the agenda. It's a bit short notice, so in terms of complete thought about it, and I'll mention nearer the time that as you will all remember, when Ockenden 1 came out, I asked the question, how does the board know that its maternity services are safe? And that question was answered in Kettering. However, Ockenden 2 now, so the same question needs to be asked again. How does the board know? Not imagine, not think, not hope, not expect, but know. And that's the topic we'll be covering. And when Mara is here on item 11, that's what we'll be discussing. And then we will be coming back to a full review of Ockenden in the public meeting at the end of May to make sure that right across the system we are fully compliant and we can answer the question in the affirmative. So that's all from me. Simon.
Thanks, Alan. A few points from me this morning. I'll start where you left off. We've got a really good and important discussion to have today on discharge, as you say. This is, in my judgment, the number one thing that all committees we need to be totally focused on as an organisation. We will stand or fall by this, not only as a hospital, but also as a system. I've already alluded to the fact that there is a big piece of work going on in the system to look at how the interfaces between care in the hospital and care in the community are organised. And it will probably be that latter decision will probably be one of the single most important operational decisions that we make during this year. And really today, it's a kind of call to arms about getting ready for winter 2022-23, because if we're going to make a success of that, the work today needs to start. And so I make no apology for the fact that we'll be bringing back updates on discharge, and as Alan's already rightly pushed for, bringing ICANN to centre stage of the incoming ICB. Discharge really allows us to unlock the second thing that I referred to in my report, which is activity. And John and Karen will talk to this, but from an activity submission point of view, we enter the planning round enviably with one of the best track records in the Midlands. Our first planning submission continues that approach. Of all of the 11 systems in the Midlands, we are the only one not to be promising to have 52-week, 104-week or 78-week breaches. We're one of only 2 or 3 that will deliver cancer this year as it stands, and we're one of a handful that will deliver the outpatient transformation. And I think I'm right in saying we're the only system that's going to do all 3. Which is a great place to start the conversation, but we cannot deliver all of that, going back to the point I was just making around discharge, unless we have the beds to put people into. I'd just like here to pay tribute to all of the teams who've helped work, particularly John and Karen, to get us into that position. This is also the #1 ask of us, of our system partners. Our system partners need us to get to that 104% threshold of activity. Not only is that basically just fundamentally the human decent thing to do for patients, there is also a significant financial incentive associated with achieving that during this year. And so their ask of us as we start to go into this new world of partnership is that we deliver that level of activity, or as close thereto as we can. We will talk more about the money and the associated challenge on the money. This is the first time in 2 years that we've done a planning round. It's the first time that we've done a planning round that isn't focused on individual organisations, but is focused on a system. And so there is a real challenge for us, which you will explore, particularly in the private ward, about where do we need to get to and how do we manage the challenge between what we are already delivering for patients in terms of services versus the financial challenge that the NHS faces. And John is leading very ably for us in that series of discussions across the system. We will spend time today starting to begin the work that we need to do on what we will review. Sorry, I should start with that. The work of the last year on the people plan. There are things to absolutely celebrate there. In particular, Emma's update on volunteers, I think, shows the difference that communities of people can make to our hospital. There are also things that will challenge us, and we will not answer all of those challenges today because it's right that we take the time to reflect on them. But our staff survey results will challenge us to have a conversation about how do we engage with staff on a systematic and different basis to the way that we have done up until now. That's not to denigrate the work that has been done up until now. It's just saying that nationally and also in our own backyard, our staff survey results can and should make us reflect. I want obviously to end today by taking my moment to pay tribute to, I think, the longest serving member of the Kettering board now. I can't see it on my screen, but I know she's there. So I'm just going to try and find her on my screen because it's always good to talk to somebody. There you are, Janet. I think it's, Janet has seen this organisation through many trials and tribulations. Her commitment, loyalty, dedication and support of the people agenda in particular. So I'm really glad that you're able to be here for today's board, in particular, Janet, to help us think through it one last time, has been unrivaled. I think it is the true reflection of sometimes of somebody's commitment is to be found in many things, but in particular, staying the course. And Janet, you have stayed the course when many others have been and gone, and for that, but also for many other things, we owe you a huge debt of gratitude. I know it is not goodbye, but au revoir, while we magically see you pop up in a new context. But in the meantime, on behalf of all of us, and particularly the executive team, and also from me personally, I just wanted to end today by saying thank you. That's it from me, Alan. I will hand back to you.
Okay, straight to Debbie, please, and then if we've got any points, they can all come together.
Thank you, Chair. I'm not quite sure how I follow that, but I will give it a go. So I'm going to start with COVID. Our numbers of positive patients in the organisation continue to rise. Today, we have 78 patients who are COVID positive. One of those is in critical care. I think what's important to know at this point is, along with COVID, we are now experiencing emergency care pressures with really high numbers of patients attending our A&E department every day. We are admitting more patients than we are discharging at the moment. So over the last several days, we've been on the highest level of operational escalation. And that unrelenting pressure is putting quite a bit of strain on our staff. So it's really important now more than ever that we absolutely concentrate on our staff, their health and well-being, that we continue to support them and support each other. And I can't emphasize that enough at the moment. But saying that, every day, despite these pressures, our staff are doing some fantastic things, and you can see in my report, I've highlighted a few of those, and I'll pull one or two of those out as I go through. Just thinking about discharge for a moment. So some of our patients do have high length of stay. They do stay with us longer than necessary. And we know that we have a challenge with sometimes being able to discharge patients into the community. And that's because there are not enough staff in the community to care, not enough staff in nursing and residential homes, not enough staff to be able to give care in patients' own homes. And that really does continue to be quite a challenge for us, and something that we will be focusing on over the next 6 months as we head towards winter. You will also hear later on in the agenda that we are now part of a national discharge programme. The Hospital Discharge Programme, this is called. So we are one of 14 other trusts who have also got longer lengths of stay and high numbers of super-stranded patients. That's those patients who have a length of stay of over 21 days. So we're part of this programme, and our Chief Operating Officer, Faye, will be talking to us a little bit about that later on in the agenda. But I am really pleased to say that we have got a whole trust effort going into discharge and making sure that we're discharging patients on time. And we are starting to see the fruit of some of that come through at the moment. So more on that as we go through the. As Simon said, despite the challenges, our cancer and elective performance is currently good, and we expect that that will continue to be good as we go through the summer and into next winter. What's really important here is that we don't let that slip, and myself and the exec team are really keen that we continue the focus on elective care so that the emergency pressures don't take over. And again, I'm sure Faye we'll talk more about that as we go through the agenda. So colleagues will recall that in May last year, we had an unannounced visit from the CQC. They did a targeted inspection on falls safety, and they gave us a warning notice at the time around safety with falls. They visited us again on the 15th and the 16th of March. We are expecting their report anytime. I spoke to the CQC yesterday. I am very hopeful that that report will be in within the next 4 weeks. So, but the next board, I'll be able to update you further on that. So I noted earlier that our staff are doing some fantastic things every day. And I have highlighted those in my report, but I want to just pull one of those out, and that's the call for concern service. So this service was put into place by our critical care outreach team. And this is where a relative or a patient can contact them directly if they are worried. So if they feel unwell, they are worried about their safety or the care, they can contact that team directly. We're the first organisation in the region to put this in place. And I'm particularly impressed about this for, well, the main reason is the team just went and did this with no additional funding, no additional project support. It's something that they just put in place on their own. Feedback has been really positive so far. They're having on average 1 call a week at the moment. So it's not much, and they'll be formally reviewing this in 6 months. So really looking forward to seeing the evaluation of that in a few months' time. I can't go today without mentioning the staff survey. So I think colleagues are aware now that the staff survey results from 2021 were published yesterday, and the results show that staff experience is not where I or any of us would want it to be. So what I want to do at this point, I won't go into any detail on that at the moment because we are currently working through that. But what I do want to do is just assure the board and the public that myself and the exec team are fully committed to improving staff's experience at KGH to make sure that it's a great place to work, that people want to work there and they want to stay there, but also that we are, as an organisation, giving excellent care, which nobody would want to argue with. So I would like to finish on business planning, which again, part of our agenda today. I've been really impressed so far with the amount of work that's gone into our business plan this year. And I would particularly at this point like to thank Faye, Karen, Anil, and John, especially for all the hard work that's gone into this so far. And before I finish with CQC, the Falls, I should also mention a massive thank you to our nursing team, senior nurses and our ward managers, especially in medicine, who've put an awful lot of change into place over the last year and done a fantastic job with sustaining that change. So thank you to them also. I'll stop there, Chair, and take questions.
Okay, any questions or comments on any of 3 reports that were made there? Alice.
Just a really quick one, Debbie, on the call for concern project, which sounded quite interesting. But on that, and I guess a bit of a broader question, on projects like that, where we hope that the benefits presumably are not just in that direct team, but they are in different areas, how have we assessed what we think the benefits are going to be so that we can then track them when we get to that evaluation piece?
Yeah, it's a really good point. So the team are doing a PDSA on this. So basically, they are trialling it for a period of time. They are expecting that the benefits will be around the deteriorating patient and being able to get to that patient quicker than they perhaps would normally. And I think the important thing here, Alice, is you know yourself, you know when you're not well, much more than perhaps what your blood pressure might be telling you, or perhaps what a nurse might think or a doctor might think when they look at you. So the benefits are all outlined as part of the Plan Do Study Act pilot, and I'm happy to take you through that if you wish when you're next on site. It's quite an exciting project, actually. Rabia may want to comment on it. She's probably closer to it than any of us.
Thank you, Debbie.
Trevor.
Simon, thank you. Well, thank you all of you. But Simon, on your point about the fragmentation of support when patients are discharged, that clearly the actual services provided there are not our services, but we are part and parcel of the system. We need to make sure they're right. How can we make sure that's enhanced? Because they are fragmented, not just fragmented, but the quality of them is extremely variable. And I suppose I'm also open to how do we ensure that the patients' care, a bit of a hobby horse today, patients, carers, etc., are able to feed back on that quality, and in fact how communication takes place when those services come to an end and people are then passed on to whatever is their ongoing position, whether it's with their own carers or whether it's with no care support at all.
Trevor, I think that's a really good question. Both points around quality and fragmentation are right. So for colleagues who aren't aware, we have probably 80 or so domiciliary care providers in this part of the county, which when you think about trying to make that work at an individual patient level, it's just almost impossible. As Alan's already said, when you think about the distribution curve of quality, and you try and do that across 80 different providers, it's just what becomes almost a functionally impossible task. The same is true for our community beds. Our community beds are not organised fundamentally into single blocks. They are scattered across the county in quite small units, as I think you'll know well, Trevor. So I would suggest that the way in which we get into, so the proposal, first of all, the proposal that is now being put forward is that we will consolidate the management of Pathway 1 into a much more concentrated space, so that there will be single leadership, single accountable officer, and then to start to look at how we organise care that flows from that, which hopefully will give us a better understanding of the quality. Even more radically, the proposal on the stocks is that we start to consolidate our community beds. So instead of having thank you, yes, Pathway 1, Lisa, thanks for challenging and giving me the corrective. Pathway 1 is when you might need to go home. Pathway 0, when you will go home basically on your own recognizance, you can walk out of the hospital. Pathway 1, where you might need some tasks with assistance with the tasks of daily living. Pathway 2, you might need some more intensive support or a stay in a residential or nursing facility, and Pathway 3, long-term care. So in terms of Pathway 2, the community beds, the proposal is that we will reorganise those into a much bigger, from multiple small areas into a bigger block of care, and again, consolidate the management of that. The last thing you said was about patient feedback. These proposals are coming from the feedback that we've had from patients, and also from the case reviews that have been done that have pointed out that the way people experience care is very, very fragmented. So they are based on the feedback of real live cases and what people have said they want. And I would suggest that we give that some scrutiny through next month's quality committee, because this is at the heart, and going back to Chris's very good point about reason to reside, getting this right, Chris, will be critical to making sure that patients get a better experience of discharge. And going back to Annie's story, that we actually manage to get people out and help them stay safe and well when they are out. So if it's agreeable to everybody, I will arrange for it. And Becky's giving a tutorial, a much more elegant tutorial than I am, in the chat for those who really want to know what Pathway 1 through 3 is. So you're getting your educational input for the morning as well. If that's agreeable to everybody, we'll funnel it through that route so you can see the proposals for yourself, because it's right that we should all comment on them. Thanks, Trevor.
Sorry. Lisa and then Debbie.
Thanks, Simon, for that. I suppose from experience and from what we learned from Annie's story, building on what Trevor said, I'm joining his hobby horse, which is information and support for relatives and carers, because actually a discharge is also about the expectation of the informal support network when you are back at home. And from personal experience, trying to get information in what sometimes feels you've been asking for it for weeks, and then they suddenly tell you at the last minute that mum, dad, relative is going home, can be really frustrating. So I think what I'd also like us to see as a system, and for the hospital to be supported in, is that actually information for residents and for their carers is much more readily available about what you can expect, but actually what you also have to deliver. Because it's not all about services being delivered for you. Sometimes you are required to go and put support mechanisms around your family.
Thank you. Finally, Debbie.
Thank you. That's a really good point, actually, Lisa, because that support is there, but perhaps the public don't know enough. So yeah, I just wanted to follow up on the patient experience and feedback comment, really. So we received some complaints around discharge, and we'll talk about complaints later on in the agenda, but we also received many compliments And every day I am receiving letters and thank you cards of the care and communication that's good within the organisation. And this is something that Fiona and I have been discussing as part of the complaints work and how we learn from excellence as well as learning from the complaints. So just wanted to make that comment. Thanks, Chair.
Okay, thank you, everyone. We've had a decent conversation about this. I do think there is a sort of public awareness comms element for this. Anecdotally, the number of people I know who've gone into hospital who, from my point of view, you would expect to return home perfectly all right after an orthopedic or surgical operation or whatever, seem to think they need all sorts of care at home, including a hospital bed and nurses and all sorts of things. So I think there's something about the public expectation around what happens when you come out of hospital in many cases. However, all a good conversation, as Simon said, what he's going to bring back through quality committee should cover it. Okay, thank you very much, everybody. Integrated governance report. I would just make the point that you're a little bit over time, so if you want your coffee break, you'll keep these reports nice and tight. Andy first on where we are with the IGR. And perhaps I can help Andy out with this one a little bit, because obviously we had the NGH board yesterday, and we agreed there that it was very important that we had a realistic assessment, not an optimistic assessment, but a realistic assessment of when we might get a comprehensive IGR. There was no particular sense of criticism. We were concerned about the workload in the informatics department, staff working very late, trying to achieve things. It is always far more difficult to do this stuff than people think it is. I'm reluctant to agree a date for going to committees in common and therefore boards in common, because the entire thing is not pointless, but undermined without having a completely comprehensive IGR to allow us to do compare and contrast. So on that basis, Andy has agreed to go away and think about it, and is meeting with various people, which he can talk about, I'm sure, over the next week or so, at which point we'll tell you where we are on the revised best estimate of when we will be moving to these committees in common, and therefore boards as committees in common, with a view to giving you as much diary advance notice as is possible, because I'm very conscious that you all said diaries were a big problem if we change the dates for things. So I hope that's been a helpful comment, Andy. Andy, over to you, and then we'll pass to Debbie to take us through the actual reports.
Thanks, Alan. Yeah, I'll be brief. I've got the note there. So firstly, I'll start off with an apology, colleagues. Really, the where the IGR isn't where I'd hoped we would be. There's numerous reasons, technical, data issues, and staff issues, which I won't go into now. But certainly there was a level of optimism in what we hoped we would achieve. So what you have before you is 26 metrics that have got some validity and will withstand scrutiny. And as you went through the committee process, you will have had that augmented with other reports and other bits of data to help give you that assurance along the way. As Alan said, we're looking to what's left to do. Those conversations about the remaining metrics have been ongoing continuously since this pack was finalised for this board, and we'll continue to do that. And we'll put when we do have a firm timeline, of which I will be able to stand behind with confidence, then I will let you know on that. But just want to reassure you at this point that work is ongoing to try and chip away at those metrics, and I just appreciate your patience and understanding as we get there. So thank you.
Thank you, Andy. That's helpful. Debbie, over to you to compare the no doubt crisp reports from committees.
Thank you very much. So given time constraints, if I can just ask colleagues for salient points. Let's start with quality and safety, please, and Chris.
Thank you. I won't go over the things that are otherwise on the agenda, like complaints, but we had a meeting on the 22nd of March. We discussed COVID. a long discussion about mortality and learning from mortality. And I think as an organisation, I perceive we're in a good position from learning there. We discussed Ockenden, first report, and also the SIs in maternity and the SIs in general, and the estate incident, and very positive meeting in that respect.
Thank you, Chris. Fiona, is there anything you'd like to add?
No, thank you, Debbie. That's fine.
Thank you. And Rabia?
No, thank you, Debbie.
Thank you. Let's move then to performance, finance and resources. And Damien?
Yeah, hello. Morning, everyone. So a lot of what was discussed in PF&R has already been covered. I would just summarise it as saying, look, there are some very good things from an operational performance point of view, especially relative to the Midlands and East region. So in particular, cancer, elective care recovery, I think lowest number of 52-week breaches in Midland and East region, which is, I think, something to be celebrated. And ambulance handovers, I think the numbers have improved month on month there, and a much lower level of breaches. The three areas that were highlighted as areas still for significant improvement, as has much been discussed this morning, discharge, and I think we're going to hear about that a little bit later. The only thing I would kind of add on that is there is obviously the wider system challenge of, are the care packages available so that people can be discharged? But a point that I think really got emphasised is that there is a whole host of things internally that maybe don't work too well in terms of discharge. And we need to be confident that we fix those things, as well as consider the wider system. I did a ward visit this week, and I actually spoke to a patient who had been treated at KGH multiple times, and they themselves said that their discharge experience on different wards was very different. One was very good, and one was actually pretty bad. So I think there are some internal things, and the ward nurse actually said, look, it's a lot to do with the availability of consultants, discharge letters getting produced. So there are some internal procedural things that I think need to be looked at. I'm sure we'll hear about that later. Diagnosis and theatre productivity were the other two areas that are particularly being looked at in terms of improvement. I think diagnosis has had some capacity issues, and that is being addressed. And theatre productivity is the subject of a transformation programme, so hopefully we'll see that improve. On the money, I think fairly pedestrian. We are anticipating to break even at the end of the year. I'm sure John will say more about that later. And from a capital point of view, again, we are envisaging that we will spend the lion's share of the capital plan. And I think that's going to be very tight and to the wire in some areas, but that is the anticipation.
Thanks, Damien. John, is there anything you'd like to add?
Yeah, thanks, Debbie. I'll be brief per the brief. So probably two things to flag with board colleagues. We have posted a surplus of about 2 million to month 11. We went through with Group PFR quite a detailed forecast outlook to year end, which is, as Damien has said, I gave assurance around getting to a break-even position. Part of how we will go about doing that is we will need to give some money back to the system. So our forecast, our best assessment of forecast would leave us in a position where we would be posting a surplus of some £600,000. We agreed with system colleagues that we would deliver break even with best efforts. And given that KGH received £12.7 million worth of system support money in the second half of the year, when no other areas of the system did receive any, I have agreed, in order for us to land a break-even position, we pass some of that money back so it can be redistributed to other parts of the system, including NGH. So it's important that I note that to the board. Secondly, there are a number of specific accounting issues around accruals and whatnot that will require audit validation, in particular annual leave. Our GEM is briefed on that because we took a policy paper. Our group executive management team were briefed on that as I took them through a policy paper not that long ago around what we will allow and not allow around annual leave. I will need to take that paper. I've shared a draft with our external auditors. I'll need to take that paper via audit committee. That will be an increase in our annual leave accrual, just for clarity. And then on the capital side, it's been a bit of a whirlwind last 3 months on capital. Quite a significant amount of spend around digital that will really hopefully put us in a good place in terms of investment in digital infrastructure at KGH and across the group. As Damien has said, I provided assurance to the committee, Finance and Performance Committee, that we will land as close to full spend. I'm expecting within 100, 200k of our overall plan, which was 19.5 million. We are doing the usual stuff at year end around vesting, which is where we take on ownership for goods or services in advance of physically receiving them. That's a usual year-end accounting process when you're trying to balance the numbers. I'm comfortable that I have full oversight of that. So no risks to flag in terms of material underspend there, other than to say, and I think I've raised this to board and audits committee ever since we were notified of the significant amounts of money for digital transformation capital funding, or TIF as it's called. Some of that stuff is subject to a kind of accounting review, in particular the capitalization of cloud accounting, of cloud computing services. I won't go too much into this meeting now. Audit committee are briefed, and I'm comfortable we've got an adequate basis of justification to take that 3-year end audit, but clearly we need to go through that process as we close out year end.
Thanks, John. Faye, anything you'd like to add on performance?
No, thank you. I think Damien covered it.
Lovely, thank you very much. So let's now move to people, and Janet, please.
Thank you. A lot of what we discussed is actually on the agenda today. Key things to note, the absence rates going up, clearly in line with things that are happening around COVID. Statutory and mandatory training, there's a big push needed on that, including appraisal, which obviously is important in terms of staff getting a conversation with their manager, and a discussion around motivation of staff linked in with psychological support. However, in terms of things that are happening in the organisation and things to note, the Dragon's Den work that happened pre-COVID, one particular piece that I recall from that was the Spice Girls, the older Spice Girls, and the work that's happened on Lamport and Twywell. And I'd just say how significant I think that approach was. And I know that there's a big piece of work happening now around looking at what benefits can be made available for the workforce. So thanks, Debbie.
Thanks, Janet. And Mark, anything you'd like to add? I can't see you yet. Mark?
Oh, I'm definitely here. Morning all. Just one small thing, because we've got obviously a larger agenda item later. It's just around vaccination as a condition of deployment, just to confirm to the board that that has been revoked in its entirety. Just thinking back to our last meeting on the 31st of January, that was in debate at that particular time, but obviously we know that nationally now too, but that was all. Thank you.
Lovely, thank you. Let's go to digital, please, Alice.
Thank you, Debbie. Just quickly then to say, we spent quite a long time talking in the last meeting around the rollout of the TIF funding that we've been given, that's been referred to by John, and making sure that we've got a robust plan in place to spend that and spend it in a way which is going to be effective in the long term for our transformation ambitions. So I think we acknowledge that that's going to be not a quick win in terms of the overall transformation, but it's hopefully a quick win in terms of spending that funding to start us on that road, but that the challenge is going to be how we work over the next couple of years to embed that and embed the wider transformation that comes along with the technology spend. So we spent quite a long time talking about that. We also, since the meeting actually, but I think it's important to flag here, we had a sort of roadshow, if you like, that Becky and Andy put on around the technology and the solutions that are going to be part of that outpatients transformation piece, which I went along to, and I think a number of other people did at some point in the 2 days. Just wanted to thank them both for that. It was an excellent opportunity, I think, for staff to get a sight of what these things might look like when they come to us. They will hopefully look more like an all-in-one solution when our patients and staff see them, but it was exciting to see the functionality that we will have within our trusts. So really, really pleased to see that. Just in terms of the global situation at the moment, we were also asked to do some additional work checking our position on cybersecurity across the 2 trusts, and we completed a review on that. Andy's team completed a review on that, and subject to a few minor things that needed to be tidied up, we were happy that our position was as good as we could get it to be from a protection from cybersecurity attack issues as a result of global uncertainty going on at the moment, and have responded to that effect to the national team. The Northampton EPR system continues to experience delays in our funding position, and I know this is the Kettering board, so I mentioned that, and you're probably all thinking not relevant to me. At the moment, I think there is plenty we can continue to do at Kettering, plenty on our digital agenda, that is not holding back, but inevitably that pushes back the date, sadly, whereby we can, in a fully collaborative way, look at patient records across the 2 trusts. So I flag it here for that reason, if you like. We're doing all we can to keep that delay as short as we can. And as Andy said, health intelligence continues to be a worry and a challenge in terms of delivering all the demands that are on that team. And I know that Andy and Simon have been trying to come up with some creative options about how we might address that challenge going forwards. I think that's all.
Thanks, Alice. Andy?
Yeah, thanks. The only thing I'd add is we've had some really positive conversations with national and regional colleagues about unblocking the understanding around the EPR funding regarding the NGH situation. And the other thing to say is it's absolutely true that the overall situation regarding a combined or an aligned electronic patient record is a challenge, but there are things that we're doing in parallel to try and make sure that we're still doing things together. So, for example, working together on how we use Connect across the group, how we have the same electronic medicines and prescription administration system, and the same system that we use for scanned records. So there are patches of things where we're trying to mitigate that delay in parallel as we go through. So yeah, thanks Debbie.
Yeah, thanks Andy. And I just want to echo as well, thank you to Becky for the road shows, because I think it's the first time that I have in quite a few years heard our staff talking about and feeling excited about outpatient transformation. So it was a really good day, so thank you. Alice, I think I'm coming back to you now with CPC.
I think you are, Debbie. Yeah, absolutely. So last couple of meetings, we have looked at various things. Group people plan, which is further down the agenda, so I won't say much about that, but we gave that a thorough talking through, if you like, particularly some issues around HCA availability and training, and also around management capacity and capabilities as well. We spent some time talking about, which no doubt we will focus on later as well. We also talked about the clinical ambition and where we were going next with the communication of that and the rollout of that, and particularly about reflecting how that is going now. We are starting to actually take decisions based on that, and how the response of the clinical community is going in quite a balanced way around some of the challenges and some of the things that were going really well, and how we continue to give that momentum. And as I've mentioned in my digital hat on, we also spent some time looking at the outpatients transformation plan as well.
Thank you. Simon, anything to add?
Just one thing, picking up on the outpatient transformation plan, and congrats to everybody from finance, digital and transformation for the work that they've done over the last month. Getting the purchasing over the line has been a Herculean labour for those who aren't aware. Of course, it's one thing to buy a load of stuff, it's another thing to implement it. So one of the things I'm particularly hoping the F&P and digital committees will look at, and I certainly will be taking a keen interest in April. When I get back from leave, I'm meeting with Andy and Debbie to look at what is our plan for implementing all of that kit that we just bought, because we've created a real positive vibe in the organisations. The roadshows were really good. People suddenly saw, oh, this technology thing, it really can deliver for us. So it was really incumbent upon us now to actually deliver it. And back to the point about being realistic about what we can deliver, be clear about what we can deliver in the year ahead. So I'd appreciate both digital and F&Ps taking a look at this in terms of how it's going to work and what we can deliver in the year ahead. Thank you.
Thanks, Simon. And I'm also really excited that the TIF project manager lead is going to be joining KGH's senior leadership team as our digital director. So that's another plus that we can get this out and across the organisation after April. So just to touch on audit, no meeting has taken place since our last update. And with regards to Strategic Development Committee, there are no specific items that need to be raised for escalation to the board. So I'll stop there, Chair, and ask if anybody has any questions from the committees of the board.
So, anybody want to pick anything up from that, looking across this organisation as a whole? No, Trevor.
Just one small thing, and it's on the theme of discharge, just linking with digital. Andy, I didn't hear anything about the Northamptonshire care record, particularly given that we're sort of saying about the delay in terms of talking between the two trusts, but that's the wider projects. I think that's crucial in terms of making sure the discharge part works.
Yeah, thanks, Trevor. And yeah, it's not good news in that we're expected to go live a week or so ago. There's some challenges, some issues associated with the GP data that's been discovered, that's been looked through. The view of the Northamptonshire Care Record Board is that, while it's extremely regrettable, they wanted to make sure we don't go live before with data that causes sort of concern and undermines the overall expectation of that. So work's taking place at the minute to try and understand why that why some of the data that's coming through that shouldn't do is being shown, and seeing what can be done about that. So please be assured I will be making a big fanfare when it finally goes live, because I tell you what, it'll be a big outpouring of relief at that point for me as well. So yeah, it continues to be a challenge. However, what I would say, in the meantime, the other data feeds still continue to be tested and going in. So what will happen is, whilst the GP data has been the catalyst to start the ball rolling, when we go there, there'll be NHFT and NGH data ready for other partners to use pretty much around the same time as well.
Thanks.
Simon.
And taking shameless advantage of the interface that we have with Janet in between roles, I think this is a critical item for the ICB to pick up as it meets. This is something, you know, that is at the heart, I think, of what making the ICD a success. If we don't get this right, and then a lot of the things that we are talking about today won't happen. And I'd really appreciate your support, Janet, in terms of following this up from a quality perspective of the ICB, as the ICB kicks off, as well as from all the digital issues. Thanks, Janet. Appreciate it.
Anybody else? No. A couple of thoughts, really. One, the history of NHS computing is riddled with problems of GP data quality and reliability and proper use and all the rest of it. So we shouldn't be surprised that they're usually overcomable, but they always take longer than you think. Lesson number 2 of the day, Andy, really. Always takes longer than you think, particularly with GP records. The second thing is, I worry that as we try, the digital equivalent of open books and accounting is called information governance. And we need to take a very liberal view of information governance. We are all part of the NHS. There are endless examples of successful sharing of data. And when information governance people start to raise flags, it always strikes me as sort of second last refuge of a scoundrel, really. last refuge being statutory duty. I think we just need to give a message to all our people that this information governance issue needs to be focused on. Yes, we have to comply with the law, of course we do, but we have to be creative. The third thought, thinking back to the comments on the money, it shouldn't be a surprise that this year of all years, central budgets were held rather longer than they might otherwise have been, given the COVID surge through January and February. But it has made life difficult, as John said. And the lessons of the story is be careful what you wish for. When Andy bid for 10 million quid TIF money, and I think in his head he thought, well, we might get some of it. And when a couple of days later he got all 10 million, his first reaction wasn't joy, I have to tell you. So these things can be very difficult. It shouldn't have been, but you obviously can't spend money before you've got it. So it has been a huge challenge, but it's worked very well. And I've certainly had great feedback from the 2 demonstration days. And the third point is not to, whilst I recognise all the mitigations, as you would call them, about getting the getting 2 hospitals to work together, clearly the Northampton EPR delay is going to have an effect on what can be done around the clinical strategy, around some of the patient flows and patient changes and so on. And, right from the start, we said digital was a great enabler. And, it's absolutely true that lots and lots and lots has been done with digital if you think back 2 or 3 years. I mean, it's quite remarkable. The byproduct of that, of course, is lots and lots and lots more needs to be done with digital. And it does end up becoming quite a pivotal factor in the whole process. So thank you for that. And final comment, I didn't know I was so influential. You're now completely back on time. And we can go on to the National Discharge Programme, continuing theme of the day, discharges. And Faye, over to you. Take us through what is a pretty comprehensive bit of data explaining the discharge issue.
Yeah, thank you, Chair. So I was asked to come and talk today about discharge and what we're doing at KGH in terms of winter preparation. But actually, it's something that we absolutely need to act on now, given the pressures. And as Debbie alluded to earlier, we've got near on 140 patients currently in our beds that are affected in some shape or form from COVID, and that causes major disruption across the organisation. So the government are absolutely saying that discharge is top of their priority list, and we are not unusual with the pressures that we have on discharge complex. And as we've talked about earlier, a number of agencies and partners are involved in discharge planning for patients, which makes it really, really complex. And as Simon mentioned, we've got 80 providers of care across the county. So there's lots of handoffs when we're trying to plan patients' discharge. But there are a number of reasons why we absolutely need to get this right as we head into winter. The first being obviously ambulance handovers, which we've talked about earlier. And if you see slide 16, you can see actually from a KGH perspective, we're doing really, really well. But I have to say that doesn't happen on its own. There's been significant amounts of work that's happened with our accident and emergency team, particularly led by Ali Gambi and Adrian, who's the clinical lead. There's a real commitment and determination to offload ambulances when they arrive. And in fact, when we do have patients that go beyond an hour, we have some quite upset nurses actually and doctors, because that's not what they want to be seeing for our patients. And they absolutely understand the importance of getting those ambulances back on the road for those patients that are actually more vulnerable in their own homes while they're waiting to be seen and supported. We have a big agenda in terms of elective care. We absolutely want to get back on track for those patients. We have very few 52-week patients waiting. We don't want any more, but we can't do that and protect our elective capacity unless we have flow through the organisation and that we have discharges. COVID is predicted to surge over the next couple of weeks, and we've already seen it over the last couple of weeks. We had roughly about 50 patients in our beds, and that's now tripled. And as I said earlier, that's having a significant impact and disruption in terms of how we manage patients and beds through the system. We still have to keep to strict IPC rules. And because of that, it makes the impact of flow out of ED really, really difficult. So discharge is really, really very important. And notwithstanding the impact that it has on our patients, we do not want patients in our beds any longer than they need to be, because they start to decondition. We know that we have a significant number of patients over 65 years old, and being in hospital once they're medically fit is absolutely not the right thing for them. So as mentioned earlier, we are one of 14 trusts that have been identified or invited to be part of the National Discharge Programme. And actually, we see this as a real opportunity for support and learning. So there's 4 work streams that have been identified. One is obviously the one that we're being involved in, which is the hospital-only discharge programme. There's a work stream called Interface, Community Healthcare and Adult Social Care. And actually, as a system, this is a real benefit because every one of us is involved in it. So there's real opportunities as we go through the programme over the next couple of weeks. I've just mentioned the offer of support. So the emergency care improvement team have offered us support to come in and help us with some of our programmes of work. But in fact, they've been really impressed by our action plan and some of the things that we're putting in place already. So what I've asked them to do is actually come in and almost check our homework. Are we doing the right things? Do we have it right? Are we on the right track? So they're actually coming in next week just to have some oversight and to see if there is anything that we're missing. We've also set up a weekly task and finish group or a steering group in terms of managing discharge. And you'll see within the pack that we've got 4 main work streams that we're actually focusing on. And in a second, I'll just talk you through 2 of the work streams that we've already started to see some real benefits from. So the steering group meets weekly. It's chaired by myself, supported by the medical director, Rabia, and we've also got a number of members of the teams from all of the MDTs and also 2 junior doctors that have also joined us, which is really exciting actually, because they've brought a whole different kind of dynamic to the meeting. And actually, it's going to be really powerful when we start to roll out things like criteria-led discharge. So we absolutely need support from our partners. We talked about that earlier, but actually there's a significant amount of stuff that we can do internally. So there's 2 particular projects that I'd like to just mention that we've been working on. One is around improving board rounds. And if you refer to slide 13, you'll see some of the work that we've started to do. And this is a piece of work which is basically focusing with the whole MDT on the ward, looking at what is it a patient needs? What is it the patient needs today, tomorrow, to get them home? As I say, it's a whole MDT approach, and it's also very action focused. And I think if you see slide 13, you can see that results almost speak for themselves. We started with 5 pilot wards back in October, which seems like a long time ago. But as we've already talked about, embedding culture and change is really time consuming and very difficult, and it doesn't happen overnight. But what you can see there is over the course of 5 weeks, we started to see a significant reduction in the length of stay on those wards for inpatients. We started to see an increase in patients with a length of stay of less than 7 days. And we also saw a reduction in the number of patients that were in there for 14 days. Leslie Watts, who's the chief executive, who is leading this piece of work, visited us last week. This is one of her second visits, and I know that she'll be coming to visit us again. And we took her to a couple of the pilot wards, and there was a particular ward sister called Caroline that really stood out for all of us. The passion and the determination to get this right for patients was really, really, well, it was commendable. And in fact, Leslie wanted to take her back to Chelsea and Westminster with her because she was so impressed with some of the work that she's doing. And that's the piece of work we've got to do around culture and behaviour. We've got to make it important for the staff on the ward to get people home and to plan discharge, not just in isolation, but with the patients, as we talked about earlier. The second piece of work that we've been working on is around complex discharges. So these are patients that basically need support upon discharge. Some patients may need to go into a care home. Some patients may need to go home with a package of care or rehabilitation, as we've talked about earlier. And I completely accept that slide 14 is very busy and there's lots of information on there, but it was really difficult to try and condense it down. But there's two things that I want to sort of draw your attention on to here. A few weeks ago, we started to look at the whole discharge process, and what we found out was that it was taking up to 18.5 days from the point a patient was medically fit to a point of discharge. And the red and amber and green boxes in the centre of the two presentations on this slide kind of illustrate how long it was taking to get from the start to the finish. So I'll just quickly mention that. So the first box basically says a patient from being medically fit to an SBAR completed on average takes us 1.6 days. That SBAR, or that continuity of care form, which basically describes what a patient needs upon a discharge, then goes to the cell, the discharge cell, where decisions are made on whether a patient needs a support on discharge and what that looks like. That was taking us up to 3.8 days. That referral then passes over to our partners and they have a look at it and they decide what they're going to do with it. And then they agree a pathway. That was taking 11 days. At the point then a pathway is defined and a care package or a home is made available, that was taking another 2 days. And that is the journey that our patients are having to experience. So Kate Hepton, who's one of our capacity managers, has started to do a piece of work with the discharge team, and we now start discharge planning at the point with the patient on admission. That happens in urgent care. What we've seen over the course of 5 weeks is a reduction from 8.5 days down to 12.5. Clearly, that's still far too many days, but we are absolutely on the right direction. What that's also enabled us to do is reduce the number of super-stranded patients, so patients that were over 21 days, down from 136 to 77, which I think the numbers really do speak for themselves. So there's a number of other pieces of work that we're doing. We're looking at internal delays, particularly around aborted journeys, so journeys that have been planned to take a patient out and haven't happened. And sometimes that's down to communication. Sometimes that's down to cut-offs at care homes and the old problem of TTAs not being ready. So there's a whole piece of work that's looking at what we can do around that. Kish Patel, who's the Chief of Division for Medicine, is also looking at IV antibiotics. And we're already in a really good position in terms of the virtual health ward, KGH at home, which takes patients out and continues their treatment out of the organisation. But what we found is actually there's still between 2 and 3 patients a day that we could be getting out on either IV antibiotics or converting their IV antibiotics to oral therapy. So there's a task and finish group being led by Kish in terms of what else we can do to move patients to a different environment for their care to continue. We've also kicked off a PDSA cycle, a pilot, looking at frailty this week. We've had the frailty service in accident and emergency for probably 12 months, which it kicked off during COVID. What became apparent is that only between 2 and 3 patients were being streamed to that environment every day, which when you think about our cohort of over 65 patients, that doesn't seem quite right. So we've changed the way we stream patients, and over the last few days, we've seen those numbers grow to approximately 10. And I'm pleased to say yesterday, 10 patients were seen and not one of those frailty patients needed admission because we were able to wrap some crisis support around those patients and get them back home as quickly as possible. So we've already seen some successes in terms of the work that we've started. There's more to do in that space. But also, I think the other thing that it's enabled us to do is release some elective capacity back into the bed base for our electives. So back at the beginning of March, we started to do elective orthopaedics, but in order to do that, we needed to return their ward back to them so that they could have their dedicated ward to protect that capacity for patients. So I think it's fair to say there's lots to do in that space. This is just tip of the iceberg. But I'm really, really impressed by the commitment and engagement that I've had from all of our clinical teams across the organisation. But I guess we need to be really ambitious in what we need to achieve over the next few weeks if we are to get ourselves prepared for winter, but also through the next few weeks. So we've set ourselves some really stretched targets, some ambitions. And what we need to do is we need to reduce our bed occupancy to at least 90% or less. At this moment in time, we are operating sometimes above 100% because we have escalation areas open. And as I talked about earlier, because of COVID, that's making it even more difficult for us to manage. It's also really important that we have that flexibility, because having a high occupancy means that we are moving patients around the organisation to make sure that we can get the most acute patients in the right beds. And that's not good for length of stay, and it's not a good patient experience. And we want to stop that from happening. We also need to reduce our super-stranded patients. And I've said earlier, we have made some inroads to that, but it's a high number of patients that occupy our beds, and we need to reduce that to about 10% at least. And we've got ourselves a stretch target to reduce that even more. We obviously need to protect our capacity for elective care, but we also need to recognise the impact that flow and discharge has for our EMAS colleagues and our ED colleagues if we can't turn those ambulances around and get them back out onto the road so that they can deal with those vulnerable sick patients that are waiting out in the community. So just to conclude, we are absolutely committed as an organisation and team to support discharge and ensure that we've got flow through the organisation. It's not going to happen on its own. We do need system partnership. But as we've talked about earlier, there's a significant amount of work that we need to do. But I think we're on that road, and we'll certainly embrace those opportunities that the Discharge National Programme has given us. I'll pause there. Thank you, Chair.
Thank you, Faye. Really comprehensive. But I think it probably raises a number of questions. Any questions and comments from non-execs on this particular thing? I rather thought there might be. Lisa and then Alice, and then we'll see what other hands go up.
Right, to start with, Faye, really comprehensive, really great start on those wards, and it does seem as though performance is really improving, which is good for the hospital. I have to admit, I was quite surprised in the risk section that there was nothing there about patient experience, especially given the patient story that we started with. So discharges are great if they work and they give the patient a really good experience. So I wonder whether we can put some risks in there about readmission rates, but also actually questioning, having a look at the experience of patients who are not on one of those 5 wards compared to the wards that are kind of under review, to really explore the different experiences, and that might give us even more information on which to improve further.
Thank you. Yeah, if you look at I had to look quite hard at the graphs in Faye's report, because the trend lines for the super-stranded and stranded in those wards are directly opposite the ones in the general IGR report, which is, I took a little while to work out what the difference was, but clearly having a significant and quite dramatic effect. Alice and then Trevor.
Absolutely. And I think that was the thing I was going to say, Faye, well done in terms of that dramatic impact we're having. To challenge, though, on that, my understanding was, I must admit, that ever since we'd had the interactive boards in each of the wards and we'd had the patient flow system, that we were having board rounds in all of the wards. So I'm slightly surprised that we've only got 5 on a pilot at the moment. And I suppose my challenge would be, if it's having such a dramatic impact, please, what is the delay in rolling this out to all wards? I know you've got a lot on your plate, but it seems so much a no-brainer to me, and something I thought we were already doing. So that will be my first challenge. The second one is, I'm no doubt a lot is going on, but you don't say too much about some of the sort of internal housekeeping sort of blocks around the pharmacy and drugs to take away, around the around the diagnostic tests, and also around just things like having the equipment that people need to go safely home, like aids to help them with that. Is there a project going on to really deal with those? Because you don't say too much. You say something is happening, but you don't say much about that at the moment.
Trevor.
Yes, thank you, Faye. I suppose it's twofold. One is we've seen improvements in the past when we've put project resource in, and that's not to undermine anything that's going on, but it's about how do we embed this? How do we make sure that this doesn't change? Because some of us have been around the houses for a long time. We were talking several decades ago about discharge on admission, discharge planning on admission. These things come up on, I say cyclical, well, it seems to be increasingly cyclical basis, and we do need to crack them in a way that we can embed them. And I suppose for me, one of the key things there would be, how do we make sure that our systems and processes allow for some flexibility, but actually steer our multidisciplinary teams, both our own and those that work with us, down to specific routes so that people aren't reinventing the wheel on a regular basis, because so often it's those changes to what is a cause additional time.
Where are we now? Chris and then Janet, please.
Thank you, Alan. Faye, thank you for your presentation, really good. And you've covered most of the ground, but the one thing I don't understand is age or youthfulness, if I can put it that way, a bar to frailty? If you're 60, can you get referred to the frailty service? And the second thing is, Simon earlier mentioned pejorative terms. I just wonder about being told you're a super stranded patient, might be in the same category.
Thank you. Janet. Janet? Yeah.
I'd just like to say thank you very much for the presentation. Having been here for quite a while, I'd just refer you to some work that was undertaken a while ago that might add something to what you've done, which is the work around and after one of the CQC visits, in particular around learning disability and enduring mental health problems and the relationships with the local community regarding discharges. So I'd be happy to point you in the right direction before I go. Thanks, Faye.
Okay, Becky, and then finishing up with Faye.
I just really wanted to support Faye and the phenomenal amount of effort that she and the team have put in terms of getting the ward rounds up and running, and particularly around the discharge. And just to chime in on a couple of points, obviously a lot of this is included in ICAN, not everything is, and there are some elements that Faye and the team are picking up outside the programme, but the main two things I think that ICAN is focusing on are really that making it sustainable point. As you say, we've been around some of these things before. We're fortunate at the moment that we've got Newton in that are supporting some of those systems and processes, and particularly the data. But the real focus of that is how do we embed it, and as you were saying, Trevor, make it impossible and or very difficult to go back to the way that things were done before. And that's a really key thing that ICAN are really helping the team with. And then the second part, obviously a lot of what we've talked about is internal, but there's a real focus on the community provision. How do we get Pathway 1 working in an integrated way? How do we get Pathway 2 working in an integrated way? And so that we're actually able to use that capacity ahead of winter. So to support Faye essentially in all the work that she's doing and fill in on some of the ICAN work.
And finally, Faye.
Yeah, thank you, Chair. Yes, in my eagerness to canter through that report, I did miss some points out. So thank you, Alice, for mentioning about the board rounds. Absolutely, we have already rolled out across the whole organisation now. Even paediatrics is on board with the board round methodology. What we haven't got yet is the dashboards and the outputs from those, but over the last couple of weeks, absolutely, that has been has started to be rolled out across the whole of the organisation. In terms of embedding and sustaining performance, Trevor, you are absolutely right, and that is absolutely critical. And if you look at the super stranded position over the last 12 months, you will absolutely see where we have put an intervention in and where we consider that to be business as usual, and then the performance dropping off again. So absolutely, this is critical. And I think one of the things that we're doing with the board rounds is really taking some time to make sure that we get those methodologies right. And also, as I alluded to earlier, the ward sisters have to be the change agent and the support of these programs. This cannot be led by me or the transformation team. It has to be led by the wards and actually the consultants on the wards. So I absolutely agree with you, and that is absolutely my focus. Lise, thank you for your comment on patient experience. I will absolutely ensure that I include that in terms of the risks. And in terms of frailty, I'm not absolutely sure about whether you can be referred if you're under 65. I know the whole programme is absolutely around over 65-year-olds, but I will certainly look into that, Chris, so thank you.
Thank you, Faye. I look forward to my frailty assessment if I ever come near your ED. There's no doubt quite a few other people on this call. Right. Yes, all the points made are really, really good ones. And it is all about sustainability. Many of the things you spoke about we have heard about before, and you think, hold on, wasn't that something we did before? So this is about sustainability. It's something about holding to account. It's devolution. It's holding to account. It's all the things we hold dear. Now, just to finish that, a couple of things really. Non-exec directors are welcome to join ward rounds, if you would find that, board rounds rather, if you would find that helpful. And it has happened in NGH, preferably with a particular ward, to understand how it is working across the piece. Second thing to say is that the national team will be coming back to look at this from a system point of view on an undetermined date in May. And non-exec directors will be invited to that meeting as well. So you can get from the so-called horse's mouth exactly what you're on about. But I intend to invite Integrated Care Board non-execs and NHFT non-execs to that meeting, because their execs are invited, and I think they too should perhaps hear the unfiltered version of what is going on. And the final point to make is that the NGH board yesterday, we ended up with a non-exec director championing the whole discharge issue and focusing on it for a sustained period of time. So if any non-exec director wants to take on that role and become a particular champion for the whole range of understanding it, promoting it, but also driving some of the performance management, making sure people don't forget about it, of the discharge processes, since we've talked about how important it is, please let me know in the normal WhatsApp or text or whatever way, and we shall get our two non-execs, one from each place, lined up. Excellent bit of work, Faye. Excellent bit of work from Palmer at the other end. If you look at the NGH report in the background, another example of, don't tell me I have a general problem, tell me precisely what the problem is, and then we can do something about it. And this is a clear example of that. Slightly overrunning, but it was well worth it. Back at 11:55, please. You can have your break now. Well earned, good conversations. 11:55, please. Okay, guys, 11:55, should be back. Cameras, action. Feel like Steven Spielberg. Biscuits, yes, all that. Right. Fine, thank you very much, everybody. Group communications framework. I think Mark is kicking this off, and then Teresa. Mark, I've got you actually. Are you here?
I'm definitely here, Alan. But
Oh, there you are. Yes, you suddenly moved. Yes. Okay, Mark first, then Teresa. On you go.
I haven't been moving too much. We've got. I wasn't expecting to be right now. Is there 2 items before me? I'm happy to go now. We can't hear you, Alan.
I'm sitting here with yesterday's agenda in front of me as well. You're absolutely right, Mark. Sorry, thank you very much. System operational plan. Karen, John, and Faye. My mistake again. Too complicated an agenda. Karen first, please.
Thank you, Chair. I'll start and then I'll hand over to John, and then Faye will pick up any questions as well in terms of the detail of the plan. So the paper you've got in your pack summarises the draft system plan for the operational plan for 22-23. It was submitted on the 17th of March. There's been some movement since then, but this is the plan as was submitted as a draft. And as Simon has already talked to, this is the first planning submission we've had to do for 2 years. And it is very different this year in terms of the planning round, in that we are submitting and working as a system, submitting a system plan, and we will be judged collectively on the delivery of this plan. The planning guidance does state that this is the expectation is this is the last time we'll be doing a single year plan, and we'll be moving from here into multi-year planning from 23 onwards, which would be very welcome. But as I say, this is the system plan. As we've talked about, and I know colleagues will be well aware, there are some significant delivery challenges nationally in this year's planning ask, and in particular balancing the competing priorities of elective recovery with our financial break-even. And we'll talk some more about that as we move into the discussion now, and also into the part 2 meeting as well. We've talked about already, we're starting for our system in a very fortunate place with our current performance and delivery for our patients locally, which is really positive. And we know we can always do more. We want to do more for our patients, but we are in a very good position. And we've heard already that we're one of the leaders in most aspects of delivery for our performance, which is excellent. Our biggest challenge, however, which we'll come on to talk about, is the system finances. And there continue to be ongoing discussions to reconcile delivery with finance and performance. So if I just pick out a couple of the points that are raised in here, just pick out some of the key things around the submission, and then we can move on to John, who'll focus specifically on some of the finance points. But in terms of the position around our elective recovery, we know that the target we're aiming to achieve is 104% of our 19-20 baseline. As a system, for the first plan, we've submitted in the region of 100 and between 100 and 104%. So we're doing very well. And there is further work ongoing to improve on that. And I have to say a huge thank you to Faye and the divisions, because I know they've gone around it a number of times, looking at what more we can do and looking at some of the efficiencies, productivity, and some of the transformation in particular around the impact that will have on improving our performance for our patients. We are also in a really good position, as Simon says, with the only system who have submitted, who plan zero number of patients waiting over 52 weeks. And again, more we can do to reduce that further, and we'll have no patients waiting over obviously 78 and 104, which is great news. Planning to deliver the cancer targets and an ambitious outpatient transformation programme. The other element we're working on is improving in our diagnostic performance. There is further work to be done on that, and there will be potential investments required to do that to meet the standard of, or the target of 120% against the baseline of 19-20. So we have got further work to go, and there are plans in place to review that for the final submission. From a workforce perspective, we've submitted a draft workforce plan. There's a system stress test and a review next week to look specifically at the workforce numbers and the investments required. So that work is ongoing as well. And then coming on to the finance plan, which I will hand over to John shortly to talk in more detail. You will see, and John will talk further about the deficit that's been posted, and there is further work on levels of investment, transformation, some of the efficiency programmes, because we are expected to make further progress on this in the coming weeks. I think the one point where I just want to hand over to John to just really stress is picking up on all the points we've discussed, in particular around the discharge and our plans with work with our system partners. Clearly, in order to deliver this plan, we need to be working absolutely as a system and focusing specifically on some of the discharge and creating that capacity in order to deliver the elective recovery. So this really builds on all the work that Faye has been talking about in the previous discussions, are absolutely critical in enabling us to deliver the plan. John, did you want to pick up specifically on the finances?
Yeah, we'll do. Thanks, Karen. And also mindful, we've got a conversation in the private board, so I'll park some of the specific detail for that conversation later on in terms of the detailed numbers. I think from a kind of wider awareness point of view, the context is everyone nationally is struggling with this on the money. No system has submitted a break-even stroke balanced plan, which was the requirement or request from the planning guidance. I think that says a lot. We locally are grappling with some really difficult tensions, which again are national issues, but we are kind of almost at opposite ends of a spectrum, whereby as a hospital and as a system, we are in a considerably better position on performance. So we are not flagging as part of our plan that we'll have any 52-week waits, and therefore anything kind of beyond that as well. We are an outlier when it comes to that positive performance, quite considerably. But on the money, we are also an outlier in that compared to other systems in the region, the deficit that we have submitted as part of our initial plans is quite notably far away. So we as a system have submitted a deficit plan of circa 76 million. You'll see that in the paperwork. The kind of the average equivalent, if I call it that, and I will massively caveat this conversation with there are inconsistencies in quite a number of main assumptions around the money, and I'll talk through that again in detail a bit more later on in the private session. But a kind of comparable number to get us in the pack, so to speak, would be a deficit of circa 40-45 million. I think that's important that the board are kind of cited on those numbers and that scale, that we are far away from that kind of system view. Sorry, our regional colleagues' view. We have a set of work in train to better understand some of our numbers. We've had a number of system calls, including one last night, to agree a plan of action to close through that. But I think from my point of view, we are going to get to a point where there are trade-offs or tradables between our operational performance and the money. That's no different to any normal year, but the position that we find ourselves on each of those two domains is at stark contrast. And to date, the conversations that we've had as a system on the money, as on our system plan, are quite binary, focused on the money. I and other colleagues have pushed back, and clearly we have to deliver a plan across multiple domains, and we expect the conversations that we take forward over the coming weeks before our final plan submission on the 28th of April is to work through work through those. We are receiving inconsistent messages on priorities. We are being told that the absolute priority is operational performance, and that is not consistent with the narrative that we're hearing on the money, and a view that we get back to, or indeed exceed upon, pre-pandemic levels of activity from a standing start. So that's probably me. That overall context, I think, is really, really important given how we need to play those conversations out.
Okay, thank you for that. Faye, do you want to add anything?
Yeah, thank you, Chair. Just to say that, as Karen's alluded to, it has been quite a challenge for the teams to get us to this position, particularly because there's a number of things that have changed. So things like services that have stopped, government guidelines, transfers of services from, say, KGH to NGH. So trying to go back over the last 2 years has been quite a challenge for the divisions. We started off being quite in some deficit actually against our 1920 levels, but I'm pleased to say we're actually at 102% now for a KGH, and there's still more to go at. So I'm absolutely confident that we are moving in the right direction. Thank you.
Okay, thank you for that. Yeah, I do appreciate the difficulties here, but I have spoken to Karen and to most of you. I think I do think that the 2 acute hospitals ought to be able to hit 104% without having to pour money into the private sector to achieve that number. And the other thing to remember in this is that some of this is as a system and therefore includes patients in other hospitals, in the waiters around Leicester and Oxford. So it does require clarity by the presenters and clarity by what are we counting here sometimes. So just try and remember that, guys, because we would normally only look at KGH or KGH NGH numbers. Lisa, Trevor, and other Lisa. Lisa with an E first, sorry.
Yeah, John, apologies. I'm probably going to show my lack of understanding because the system has changed so much. But in slide 6, it says, you talk about the allocations have got a natural inbuilt efficiency of about 46 million. But then you also say that they've been rebased to take away historical deficits.
Yeah. No, so it isn't as clear as it might be. So in setting the systems allocation, and again, it's a system level allocation for 22-23, essentially what's being done is we have been funded as a system to cover our cost base as at 1920 or kind of pre-pandemic levels. So the costs that we incurred at 1920 and we've reported as our costs individually and as a system have then been used as a start point for calculating our funding for 22-23. Okay. So the conversation that we've had a number of times since I've started in this role around an underlying deficit is on the face of it no longer a relevant issue, because that underlying deficit, certainly up until 1920, has been written off, and we are now being paid to cover off those costs as we incurred at 1920. As the numbers then move on from there, if I can, there are then a number of further changes made to that allocation. A national efficiency ask, 1.1%, which the Chancellor has recently announced he has doubled. A trajectory for improvement, or a convergence trajectory, that is the actual term, which seeks that where there are systems that, based on a population funding model, are considered to be, in inverted commas, overfunded, we then have our allocation tapered down so that over a number of years, 3 to be exact, we will be in a position where we are spending in line with that fair shares basis, I should say, for Northamptonshire. That adjustment, and therefore the amount of money that we are being paid above, or we're being paid above that fair shares allocation, is considerably smaller, i.e. most systems are paid more than their fair shares of allocation and continue to do so as that tapering comes in. And then finally, there is a really significant assessment, or a really significant assumption made in the planning guidance around the money, that the costs of disruption and costs of supporting, I deliberately say those two things, as a result of our response to COVID and the pandemic, the costs of doing so significantly drop. So we've received as a system this financial year, 21-22, at a system level, some 50 million to support COVID related costs. those numbers are going to be haircut by 60%. They will be reduced by 60% moving into next year. We would, because we're not sat here saying that we're going to post a deficit of some tens of millions, a surplus of some tens of millions of pounds. We would need to exit costs equivalent to those reductions in income to be able to get back to a balanced position. And also the context in which we are currently operating is that we still have a considerable number of patients being supported for COVID-related issues, and the national IPC guidance in some of these areas has not progressed to a point where that level of disruption will be zero or significantly minimised. And for Kettering, just so you know, in terms of context, that loss of income net of a small reduction in cost is about £11 million. So £11 million of the system deficit relates to KGH's inability to remove costs matching reductions in income. And again, that kind of assumption around COVID impact is going to be a challenge, and is a challenge for the majority of systems.
Okay, thanks, John. This is really complicated stuff. I just remind everybody we have a longer session on this in the private board. So if we just think about what we want to talk about here and what we want to talk about in the private board. But Trevor, Lisa, Damien, Edmund.
Just very briefly, not on a finance point, but sort of taking one of the three parts of the triangle, operational, finance and workforce. On the workforce front, is this plan growing our workforce further to actually manage that increase in activity, or is it a static position or a reduced position?
Okay, we'll come to that. Lisa.
Yeah, my question was actually more about the system. So I know we've had a chance to look at our assumptions, challenges, some of the interdependencies. But given we're going to be measured as a system, I don't feel like I've got the same level of understanding about what the challenges are for our system partners, and therefore where we are by our relationship to them exposed.
Yeah, Edmund.
Thanks. In terms of the long waits and the 52 weeks, I can see what the plan is, to reduce those over the next year. But what does steady state look like? What would the medium to long term plans be? What is the ideal, realistic waiting times that we can aim for in that time scale?
Okay, thank you. I guess the long term is the NHS constitutional standards. So Karen and then Simon, and then I'll try and wrap this up, and we'll take many of these issues into the private session later on.
Thank you. I was just going to try and answer a couple of those questions. I saw, Mark, you put your hand up. I don't know if you want to pick up the workforce question. But the other question was around the medium to long-term plan. Yes, absolutely. I mean, this is a one-year plan. We've been working across as part of the Elective Care Board and Elective Recovery, looking at how we can do longer-term elective recovery, and that's what we would be looking to do beyond this plan, and aiming to reduce those further and deliver the constitutional standards. That's work that's ongoing though, Edmund. We're by no means have completed that at all. The first part is to complete the planning submission as is now, but longer term that's what we're looking to do. And in terms of the system partners, I'm sure, I know Simon, you've got your hand up too, but I think that's a really valid point about understanding what's happening across the system, Lisa, and understanding the whole totality. And I think when we bring the final plan back, because this is only the draft submission, we will have a longer term discussion on the final plan and all the moving parts in the plan, and how we work with our system partners and what the risks are to deliver all aspects of the plan.
Okay, thank you. Quick one on the people, Mark.
Yes, thank you, Chair. Thank you, Joe, for the question. I'll probably talk about this a bit longer later, but there is pay growth of 2.6% within the plan. what we need to work through, as Karen's reference in the Workforce Summit, is where that growth is. So there will be growth, Trevor, to answer your question. The question for us in the summit is what's the feasibility of recruiting to that growth? Because if we just put growth in that we can't recruit to, then it'll be in temporary staffing and so on and so forth. But I will pick up more around temporary staffing and recruitment and requirements in the next section.
Okay, Simon. Where'd you go? Oh, you're there. You're muted. You're still muted.
Sorry, I think the absolutely salient point that the board needs to debate in its private session is Lisa Janoff's question. That's at the heart of this. I will summarise, I think, from my perspective, because I will not be with you this afternoon. I am on ICB duties, as it happens, but just to indicate, the only way we can collectively achieve our aspirations of balancing what is proposed here in terms of delivery with getting to an acceptable level on the money is if we all move together. And the subject of the debates that John and I are now in fundamentally is how do we construct a scenario that allows that. The second point I'd make is, given the issues that John's described and how badly at one level this planning guidance has challenged the system in terms of no system has been able to put a positive plan in. Alan and I have been talking about an approach that will need to be a multi-year approach to this, rather than seeing it as a one-year-fits-all approach. So I think John and Karen, John in particular, will guide you through some of the parameters in play, Lisa, about how system needs to move this afternoon. It will be obviously a key topic of debate at the first ICB board meeting on the 17th of April. You asked a question about how are we exposed? We're exposed in two ways. One is we can't do this on our own financially. The other is the operational assumptions that we're making here are dependent on us being able to protect our elective beds. And any bed that we are unable to utilise for this 104% activity threshold because it is taken up by a delayed discharge of whatever type is a potential risk to the activity trajectory. Again, you will have an opportunity to debate that this afternoon. So those are my thoughts on that. On Edmund, on your point, the NHS has not really yet set a longer term planning timeline. I would just draw out Karen's point here, which is this is the last year we will be doing 1 year plans. From here on out, it will be probably 3 year plans. So that will be an opportunity for us to consider where we are expected to be over the medium term. Thanks, Alan.
Okay, thank you. Just a couple of comments really to bear in mind as we go into the afternoon. The first one is that all the tests and assumptions should be the same between KGH and NGH. We got ourselves into a little bit of difficulty the last time. The second one is, as I look at the regional plans, I suspect there might be a degree of fiction in some of them, and we should not fall into the trap of fiction in order to get something across the line. We need to be in the realms of reality. The third comment is, I think public and our staff will find it very difficult to understand why we're in this position when £12 billion is coming out of national insurance nationally into the NHS from payments and deductions. So I think we need a clear text for non-execs and indeed execs, because we will be asked questions about this in other environments that explain very clearly why we're in this position with the national insurance payments going up for staff and for people and employers. Staff will see that money coming out of their pay packets next month, and at the same time we're telling them we're £40 million short. And the third thing to say is this has to go in on the 28th, which is the date of April, which is the date of your next meeting. So I'm proposing, and it was certainly NGH were keen yesterday, to have a seminar at some point between now and then, when we can go through this in a bit more detail before the final submission. So that we'll be looking for dates for that quite soon. But it's a bit of a test of when it will happen. And the final thing I was wanting to propose was that if we do go in with a deficit, which seems likely, I think we have an obligation to start thinking very early about the next year's 2-year plan and where we are with transformation and other items, and particularly progress on ICANN. And so I'm proposing another seminar in the summer to start the process of what is our expectation for the following 2 years as part of a trajectory that we can set for ourselves as part of responsible members of the integrated care system. So those things should all start to fall into diaries in the not too distant future. Thank you very much, guys. A lot more conversation in the private bit. Complaints, Fiona.
Thank you, Chair. I'm hoping that there's a PowerPoint presentation that can be brought up. Thank you very much. So as part of the patient experience, I wanted to focus on our complaints process and give an update on the work that we've been doing. We could go to the next slide, please. This morning's patient story is an example of patient feedback that's given to us and gives us an insight into patient experience. Through that patient feedback, what we need to do as an organisation is understand what those issues are, address those issues and learn from those issues. So just to give an overview before I go into the details of complaints responses, with the concerns that have been raised in mind, we've started a piece of focused improvement work that is going to be looking at the top 3 concerns and complaints that have been raised by our patients, their relatives and families. And the reason for linking it with our story this morning is that the 3 themes that have come through from the thematic review, as highlighted in the list of actions on the slide, is around the attitude of our staff towards our patients. The second area is the experience that our patients and families and carers have had around the discharge process. And the third area is around information on diagnostics and the timeliness of diagnostics across the organisation. All 3 of these themes are linked with communication, and that's the golden thread that goes through and the concerns that have been raised. And in the we've got a workshop planned for April, middle of April, and we will be working as a multidisciplinary team with non-execs and governors and patients to understand what those issues are within those 3 themes and take that work forward. Those themes will also be linked, and those priorities will also be linked with our patient quality priorities so that there can be wider learning. We've also, with the support from Debbie, allocated considerable time on our hospital management team meeting that we've got at the end of April to focus on the learning initially from the workshop that we have, but also recognise what engagement and support and understanding do we need from the divisions in this work. And I think learning is a key part of our complaints process. If we move on to the next slide, please. So I just wanted to give a bit of background in regards to our complaints and the journey that the team in particular have had. In 2018-19, there was an external review was undertaken and a number of recommendations were made in regards to the processes. Some of those have stayed in place and they're on the right side, the left-hand side of the slide. And the 3 areas of recommendations that have changed are on the right-hand side. The first one being the leader investigation to draft the response. And this was originally based, the lead investigator would have been within the division, usually a divisional director. However, during COVID and certainly during the period of time when the complaints have continued to be produced, there was poor compliance in regards and poor quality in regards to those responses, and therefore this has been taken over by the case handlers within the complaints team. In regards to reviewing the complaint and the sign-off, again, that was at divisional level, but that has now been taken to executive level, and Debbie now, as the hospital chief exec, now sees every complaint and signs them off. And for the last 6 months, each of the executives who are involved, whose portfolio covers the complaint, is also expected to review that complaint and sign it off before Debbie sees that. So the third area, one of the recommendations, was to exclude extensions when calculating performance, and we have been doing that as an organisation. However, through the joint piece of work that we've undertaken with NGH, which I will lead on to, we are revisiting having extensions as part of our performance, but we will be ensuring that both sets of data are produced. The timeline in the slide just gives an overview of some of the actions that have been taken by the team, and at the bottom a progress update of where we were in 2018-19 and where we are now. Recognizing that during this time and through the pandemic, there have been a variety of changes to our complaints. If we could go to the next slide, please. So recognizing our poor response rate for complaints, the initial focus was on our complaints team. So within the complaints team, we've revisited the processes, which included a process mapping exercise that was undertaken jointly between KGH and NGH. And the summary of that can be found later on in the presentation. But the slide provides a summary of, following that process and process mapping, the actions that have now been put in place and are ongoing in regards to improving the measures that we have. And I think it's key to recognize that there's also been learning learning for our staff in regards to how to manage a complaint and actually be managing supporting complainants through the process, not just managing the end result of a complaint. The next slide, please. So focusing on the complaints, following the focus on the complaints team, we've then looked at what do we need to do to support the divisions to improve their compliance, because there's been two key areas in which they are not compliant. The first one is around the quality assurance process. Now within the complaints team, we do have a process, and that is going to be now monitored more closely. But within the division, there needs to be ownership and commitment to ensuring that the complaint response actually answers the questions that have been raised by the complainant, but also is of a suitable standard that we would expect from our staff for our patients and complainants. Within medicine and surgery, both of those divisions have put a quality assurance process in place. Family health will be doing so from April, once key members of the team have had the bespoke training required to undertake this process. The second area that we needed to focus on is our internal response time. And this was when we undertook the process mapping, it became evident that the divisions either didn't use or didn't have the relevant information in regards to their complaints timelines. Therefore, we're now putting in, we've revisited the data sets that the divisions have requested and supplying them with that. We've also got weekly meetings with the divisions and the complaints team, and I've attended 4 of those in the last month. We have twice monthly scrutiny meetings with myself to review the progress in regards to each of the complaints. And we also have a mid-month cut of our data to see progress to enable us to manage our complaints. If we could move to the next slide. So this slide just gives a brief overview of some of the KPIs that we have now produced to support the divisions in their progress. I'm very keen on the simple process. If we measure it, then we can monitor it. If we can monitor it, we can manage it. So these first 2 KPIs, i.e. percentage returned by internal deadline and required further improvement, associated with the 2 areas for the division that need to focus on. You will also notice that the executive team have a KPI as well, recognizing that the new step that we have put in a while ago now in regards to the executive team and Debbie reviewing that. What we don't want is that to be a delay, and it's about how we can ensure commitment to that. We also have a a target, a KPI associated reopening a complaint, and that should not exceed 10%. But at the same time, we do not want any complainant to feel that we are not listening to them or taking their concerns seriously and proactively supporting them in that process. We will also be having a KPI associated with how long it takes our complaints team to actually draft the responses. And the reason that we don't have that at the moment, because of the complexity of some of our complaints due to the different timeframes that we have set for a response and how quickly that can be done. And this can be quite difficult, recognizing that some of our complaints come from 3 or 4 different services across the divisions, and it's about how we make sure that that final complaint responds to all the key aspects. Next slide, please. So our current position. These 2 graphs give a summary of our year-to-date in regards to our complaints performance, and unfortunately you will see the deterioration that we have had over the last year, calendar year, and the slight improvement that we have had month on month since December. Recognizing that we're at the end of March, we can't give a final percentage of where we believe our complaints compliance will be for March, but based on the information that we have, we believe it to be about 40%. So again, a very slight, small step change. Against that, we've had a month-on-month increase in the number of complaints. And as you will see on the slide, we are sitting currently at 54, and that was on the 29th, a couple of days ago. We also recognize that within those complaints, there are a number of complainants who would like to have a discussion, and rightly so, with members of our staff to look at resolving those complaints and those concerns at a more local level, literally called local resolution. So that figure may not be the final figure. Next slide, please. So our next steps demonstrates a timeline of the actions that we will be we have taken and are going to take to achieve our trajectory of 90%. And this is going to be a challenge. We have proposed and are aiming for and are committed to a 5% month-on-month improvement. And the focus for this will be particularly on the weekly meetings and the twice-weekly meetings and the proactive management of data for the divisions to be able to manage their complaints. And I think it's fair to say that the divisions haven't had their responses to complaints to be the top of their agenda, and it's actually revisiting the culture of the divisions and the management team to see this as a patient experience, not just a complaint that needs responding to. And it's key for me is the learning from that. Next slide, please. So further steps that we will be taking are taking to support our improvement program. One of the things that we've also added that isn't on the slide is an escalation process, so that if we believe that the divisions are not going to or are over their timeline, internal timeline in regards to returning a response, we have an escalation process that comes through to the executive teams, team members, and then up to Debbie. And that's, I know that both myself and Faye have had those calls. But I wanted to just update the board that literally in this last week, we've seen surgery has got no backlog of cases, and that's the first time. And that was the update for that was on Wednesday. Medicine, rather than having a weekly meeting, they are putting in a twice-weekly meeting because of the commitment that they want to give and the focus in regards to responding to complainants. And Family Health have demonstrated dogged commitment and chasing of executive members to ensure that we do not hold up their complaints as part of the process, which is really positive. And I just wanted to finalize by saying the monitoring of this progress will continue through our quality and safety committee. The last two slides, which I'm not planning to share necessarily as a part of the pack, just looks at the comparison that was undertaken as process mapping between KGH and NGH, which some members of the board will have seen before, but also a bit of an overview of the improvement plan. So I'm going to stop there, Chair. I'm sure there will be many questions, and we'll go from there.
Okay, thank you very much for that. Chris, please.
Thank you very much, Alan. Complaints at KGH have been a long-standing problem, and I think predate every member of the board. So there are three things. First of all, the culture of the organisation. In my mind, there was a failure to accept that the complaints were a learning opportunity. The second thing was, and that was reflected in the number of complaints received, we didn't learn from them. And the second part of that is management of the complaints, both the central management and the directorate management were, in my opinion, confused. So from the point of view of this paper, I thoroughly support it because this, for the first time ever, has given me some confidence that that complaints are being taken seriously and are moving in the right direction, both to learn from and giving proper answers to the complainants. And I know that this is such an important subject for our governors. So I'll stop there.
Thank you, Chris. Alice, Trevor, Janet, Edmund, please.
Thank you, and thank you, Fiona. Just to say, for me, there's two parts of the problem here, as Chris has sort of alluded to. There's having a really robust process in place to manage complaints, and we've got to do that. For me, it's a no-brainer. We've really got to do that, and I'm pleased by what I see is happening on that. That's really good to see. I know you mentioned it, Fiona, but I suppose I've still got a little bit of a question around, hopefully by going through this process, departments and areas are learning, but there's nothing in there which checks that feedback loop that you've said anyway. There may be something that actually shows that we are learning. And for me, I think if we're going to, over time, get this down in terms of hopefully complaints become a rarer thing, then we need to really be really clear about that. I don't want to use the word enforcing, but making sure that feedback loop is really happening. Thank you.
Thank you, Trevor.
Thank you. So almost picking up partly what Alice has just said, but for me, one of the conversations we've had in the past is about how little is local resolution prior to complaint. And I suppose I would rather see more local resolution in the system to actually bring down the complaints. But that then leads to a concern that you lose some of that learning by it not necessarily being formally recognised. So it's getting that balance between local resolution and keeping the learning where there's local resolution. I also have a sort of a side issue, which is Debbie mentioned earlier on about compliments and positive letters. I think for our staff, one of the things we've got to, as part of this is part of the overall process, is actually consider how we capture that and actually bring that into the equation. Because when we look at 54 in a month, in terms of the total number of patient activities on our site in a month, that is a very, very low percentage. None of it should happen, but we should be clear that there's many compliments coming into the service, and for the staff to hear about that, as well as to hear about how we fix the complaint system.
Okay, Janet and then Edmund. Janet, you're muted.
I'm coming. It keeps moving around the thing as I'm clicking it. So, well done, Faye. I think complaints are always a really complex and challenging area to find both the right process and the right way of sharing learning. What I do know in the organisation and the work that Ravi has been doing on how you share learning, you've got a great opportunity for that. But I just draw everyone's attention to the fact that the organisation is dedicated to excellence. So key to moving on, embedding all of this is within any cultural work that's happening. So it isn't about one department being able to fix this, it's about the whole organisation being able to fix it. And I do think if you're going to motivate the workforce to do that, it is a balance between sharing the good news and the challenges about complaints. But there's a halfway house, and having just experienced it, it is something that can be fixed by, as Trevor said, tackling issues really early on. And I just wondered whether the patient experience team may benefit from perhaps revisiting the way they operate, look at some different ways of coming at that, and perhaps being more active and visible with our patients. But just some thoughts, but well done, thank you.
Okay, I'm conscious of time on this. Edmund, Rabia, Faye and Debbie. Edmund.
Thanks. Around the next steps, we've got a target to get to the 90% by January 23. I think that's a good target. But the 5% month on month, are there not quick wins that we can have that can get us better improvement more quickly?
Okay, thank you. Right, let's wrap it up now. Faye, Rabia, Debbie. Faye.
Yeah, thank you, Chair. I'll be really, really brief. I think we've talked a lot today about cultural change, and certainly when I'm asked to chase the responses from people, there is a lack of understanding about the impact this has on the complainant or the patient. So there's some definite learning that we absolutely need to do there. Thank you.
Yeah, I agree. Rabia.
I think Faye covered my point, Chair, but what I wanted to highlight here is that facilitated workshop, which Fiona mentioned earlier. One of the things about that is that we've got patients on it as well. So just listening to Annie earlier on, I think it's all about culture and communication. And it is within our gift and it is within our organization to learn, like Janet, you mentioned, from each other. So having the teams from Thomas More and Pretty Ward and patients there, I'm quite hopeful that we'll get some bridge solutions out of that workshop.
Okay, Debbie, and finishing up with Fiona.
Yeah, thank you. I'm sure Fiona will want to take some of the questions. So thanks, Fiona. That was a really comprehensive overview of complaints and the actions that we're going to take. And Alice, you're absolutely right. We've got to think about this in two ways. The first one is the transactional process of managing a complaint when it comes in and responding to it properly and in an empathetic way, which we've not always done. And the second part is patient experience. So this is absolutely, as you say, Trevor, about customer care, local resolution, how we deal with it before it actually gets to be a complaint, a written complaint. And I think that's something that, again, that we're not always good at. What we tend to be good at is saying, write your complaint, this is where you send it to, rather than dealing with it there and then. Taking into account what you said about the learning and how we share the learning at that point.
Okay, thank you.
Can I just finish with one point, if I may, Chair? So this is not just going to change overnight, and I take what you say, Edmund, but complaints and the response rates in KGH has been a problem for many years. So I do want to make sure that we're taking things slowly, doing things properly. Yes, there are some quick wins, and we will start to see that with the 5% increase. And this, above all else, is a culture change for some of our divisional and clinical staff. So that's why it's going to take a little while. But I am fully committed to making this work. Thanks, Chair.
Very helpful. Fiona.
Thank you, Chair. Can I just thank our non-execs and execs for the comments? Really helpful to have that feedback from across the audience. I'm not going to go into each of the responses now, but I'm taking on board your comments in regards to feedback and how we capture that, and in particular sharing that learning. So thank you.
Thank you very much, guys. I think it's important, the board has been banging on about this for a while. I think you've responded very positively. You've explained openly and honestly what the problems were. People just didn't take it seriously. The power of shining a light on it with some really good processes is pretty powerful, and we look forward to seeing the results. And I'm sure, well, I know Quality and Safety will continue to oversee that with great care. So thank you very much for that. Second time around, Mr. Smith, Group Communications Framework.
Thank you, Chair. Yeah, so I was going to take us through 3 agenda items today, really, in terms of the communication strategic framework, which Teresa will talk to, and then we have an update on our people plan, which was already referenced, presented to the CPC, our people committee, and indeed to our governors last Thursday, which I will take us through. And then Emma will be joining us to talk through our volunteer services, which will be great as well. Just to start off, I think it's really important, if I could just start this section as the Chief People Officer again, to reference the staff survey results. It would be really remiss of me not to do so. They've already been referenced obviously by Simon and Debbie earlier in the meeting, but it's really important, and again linking to the last item and indeed to Faye's item, how culture and communication seems to be the 2 things that we've talked about quite frequently during the course of this morning and indeed this afternoon. And I think they are all intrinsically linked, because if we're able to resolve our issues around flow, we're able to create time. If we can create time, we can then create time to support, lead, and be accountable for what we do. And I think what the last point was really a really good one with regards to the complaints process, and equally how we talk about the compliments, because within our staff survey results, of course, we look at staff engagement, which has a big part of advocacy within it. And if we're not advocating for the positives as well as everybody else, then no one else will. We have to make sure we have a balance between what goes really well in our hospital, whilst of course addressing those things that don't go so well and making sure that we are dealing with those appropriately. So part of that centres around our communications and how we do that as a group and within Kettering Hospital. And so I will hand over to Teresa, who's also joined, I should say, by Sandra. So Sandra is our head of comms for KGH, who you will remember from our NED away session a couple of weeks ago, is also in tow too. But over to you, Teresa.
Thank you, Mark. So I will briefly go through how we will be doing communications from here on in. Hopefully you've all had the opportunity to read the document that we've pulled together. I stress it is a framework at this point because we are at the beginning of a journey as a communicating team. We came together last spring. I joined the organisation in June. And there have been lots of challenges for us across the way. Some of them have been structural, we're the first team to come together in the group model, and some of them have related to other bits and pieces that will play out. So what we've been doing over the last few months is actually looking at how we communicate across both organisations to our internal and external audiences, what's missing and what we need to build upon and improve. We saw a huge amount of improvement in communications during the pandemic, and this is very much within the nature of a crisis communications time. And this was an increase in interest from our communications from our staff, but also from people external to us, and a lot of people seeking information and seeking clarity. We need to build on that and develop that, and that's something that we intend to do as a team. The nature of crisis communications is that it's very transactional. It's very, this is what you need to do, this is when you need to do it, and this is where you can find the information to do it. And we need to take that and change the tone of what we're going to do and make it more into a conversational tone of voice. So the research in communications in the last few years has very much turned towards colleague engagement. It used to be rather a Cinderella service within communications, but now it's where people see that you actually get the most impact if you have a well-led and well-functioning communications team. So this is where we're going to devote a lot of our time and research. And the research has shown, and this seems a bit obvious when you look at it from standing back, but the research has shown that messages land best with people when they are delivered in a conversational setting with somebody you know and trust. That can be quite difficult to replicate within a colleague environment. But what we want to do is to supplement the communications that we'll put in place to support the executives across both organisations and the board with more first person and conversational content. We always see in events like this how well patient stories land. And what we want to do is make sure that we take colleague stories and have those representing our views and our values, and making sure that colleagues are very much at the heart of what we say and how we say it, ensuring that we're listening to them as well as talking to them. So what we need to do to make sure that we're doing this appropriately and in a fully formed way is look at how we communicate. When digital communications came on stream about 15, 20 years ago, and I'm old enough to remember when this happened, we very much moved away within communications from the physical communications methodology. We moved away from posters and leaflets and having face-to-face conversations with our colleagues. But what we find now actually is that a lot of our colleagues don't sit in front of a computer, and we need to re-explore these opportunities to engage in non-physical assets. And that's what we're going to do. In the next few months, you'll see lots of posters going up in places, particularly where our colleagues will be. We're going to introduce lots of QR codes and driving people towards looking at our Facebook pages, because we're alive to the fact that most of our colleagues, if not all of them, have access to a smartphone, and we need to make sure that they're getting the information in the way they need to. Something I heard last week was that porters in one of the organisations said that they weren't invited to events like group briefings, and they are very much invited, they just don't see the invite. So what we want to do is to make sure that we get those invites to everybody that sees them, and this is just an example. So we're going to explore more of these opportunities. We're going to be looking at how we can get involved in ward briefings and all the other opportunities where colleagues come together to talk. We're going to be supplementing how we do our external communications at the moment as well. So we have a really good, lively social media presence, and we really need to explore this and develop it and use it as an engaging platform to get more people engaged in what we want to talk about. We're also going to look at exploring broadcast media more as well, because we know these are opportunities to really connect with younger people as well as the older demographic who we have quite a good connection with already. So as I said, we're going to be moving from a more transactional communications method to a more engaging and connecting communication method. And over time, that will help support the work we need to do around cultural change. We're going to bolster the leadership comms offering that we have as well. And we were working with Debbie and her team to see how we can develop that at KGH and make sure that we're reaching as many people. And as part of this work, we're going to be offering some opportunities for board members to engage with my team so we can help you develop a social media presence if that's what you'd like to see. We'd also be really keen to promote the work you do across the hospital. So if you go on a visit, if you'd like to let us know and take a couple of snaps, we can include it in our various channels to make sure that our colleagues are getting the opportunity to get to know you as well. We really want to help you raise your profile. And finally, we get a news update every day. And I've started sharing that with you so that you can see what's happening with our coverage in both the print and local media. I'd really appreciate any feedback you have around that. So one of the things that was mentioned when I presented this yesterday is that we don't have any metrics in place. We don't have any metrics in place to measure our impact currently. And measuring communications impact is both an art and a science. So we're going to capitalise on everything that we have available to us. But what we're going to be doing is very much building feedback into what we do. We are only as good as the communications that we know that are going out. So when we do all of our communications activity, very much part of it will be feedback. And that will be both metrics that we can measure. So things like how many people open our newsletters, how many people go to a particular internet story, but also talking to people. How did we work with you? What was the feeling about the product that we delivered? Was there anything we could have done better? I've spoken to a number of trusts over the last few months who do communication, some of them who are considered to do communications extremely well. And the message that I've taken away is try everything, because there is no set method for what works in this industry. So we'll try everything. And if we succeed with some things, they'll stay within our comms mix. And if we don't succeed, they'll be binned. But we'll only know if they're not succeeding if we get feedback. So this is my plea to you. Please feedback to us on everything we're doing so that we know what works and what isn't working, what messages are landing, and how we need to sometimes switch things up a little bit. I've got a slide to show you. If you don't mind, I will share my screen. And this is just an outline of some metrics we had. Mark and I have worked together on this. Very much embryonic at the moment to consider what we will be doing and how we will measure what we'll do. 5 metrics, all based on things that we'll be physically able to see. And what we'll build around this as well is some of the anecdotal feedback that we receive as we work through the year. To sit alongside these 5 metrics, we will also put in place communications plans and strategies to support the enabling strategies that sit under the Dedicated to Excellence strategy. We've done a lot of work over the last few months with Polly and her team on the clinical strategy, working with Rabia and Matt. And we'd like to use that as a template for how we can support the other enabling strategies. We do some work already on this. We're doing some work around the academic strategy, and there are other bits and pieces in place. But what we'll do over the next few weeks is formalise that and make sure that we have documents in place to support that. So as I've said, we're at the beginning of a journey. It's going to be an exciting journey, and I'm really, really keen to see how this develops. I'm sure that as a communications team, we can move towards excellence. I've spoken to a lot of people who are keen for this to happen, and I've spoken to, as I said, I've spoken to a lot of people in other trusts who've been in very similar positions. A lot of trusts I spoke to came together as groups. So I'm aware of the challenges that we'll face, but I've got a good team behind me, and we're all enthusiastic to deliver a really good product. So thank you for your time, and I'm happy to take any questions.
Can you take your presentation down, please?
Saying that, I don't.
Okay, questions, comments, thoughts on any of that, please? Andy.
Yeah, I just want to offer my support. I think in many jobs like this, everyone has an opinion, and I think what you've done, Teresa, is set out a really good way forward that addresses some of the things that we know are already working, and also things that we know can be improved on. And I just endorse the approach. I know from conversations that I've had with people, the value of those patient stories, as you've talked about, and the individual messages, and actually in empowering staff to be able to communicate authentically with their teams and others is a really powerful way. So I really welcome this, and thank you for it.
Okay, Becky.
Thanks, Teresa. I think it's a really helpful framework. I just wanted to say, around risks and enablers for delivery, are there any key risks in terms of implementing this? Are there any enablers that you need? And I think one of the things that we said yesterday at NGH board is communications is kind of everyone's business, not just comms. So are there any other things from colleagues on this call that we can do to help make sure this is implemented successfully?
Debbie.
Yeah, thanks, Chair. Thanks, Teresa, for this paper. So I absolutely support this. You're right, communication is absolutely everybody's business. It can't just be a central comms team. So whatever we can do to support you in getting that message out and training staff, then please do let us know. It is the start of our journey, and there's some really good things in this paper. I am really looking forward to continuing working with the KGH team, especially. I have done quite a lot of comms over the last year, and I'm really thankful to the comms team at KGH for supporting me with that, especially Sandra, who I can see is also on the call today. So very supportive. Thank you.
Trevor.
Thank you. I think one of the things I've seen work in the past, it partly picks up the point is not comms is everybody's business, and that is comms champions actually in directorates and departments. And that particularly relates back to some of the intranet type comms, where comms cannot maintain that on behalf of the whole organisation. So how we do that and how we engage them, I think is important. The second thing is how we come across. Is it worth having a sort of, just as we need to take the patient's view, are there certain key players out there, council leaders or councillors, or as well as our governors, that we should be using as a benchmark to, on a regular basis, say, did we get it right? Give them a sort of a batch of our comms and just test it with them and say, what did you take away from this, to see whether or not we are getting our message across.
Okay, any other comments at all? Simon.
Thanks for this. To repeat the commitment that I made at yesterday's NGH board, and we spoke about, Alan, I am committing here to making sure this starts with all of you, because I think the point that you made, firstly, Trevor, just to come to that, I hope that there'll be some people who will be keen to develop their social media presence in support of the work that they're doing in the Trust. It really does reach out. And Trevor, we actually do know some of our key influencers. So the people on the social media front, we do have quite a large number of staff on social media who do influence the way people think and talk about us. But just to be clear, I'm committing to come back at the end of April with clear deliverables on a 3 and 6 month timeline so that people can start to see and feel the difference that we need to make. And your ideas and contributions into some of that will be very welcome.
Thank you. Lisa.
2 comments really. Comprehensive strategy, a couple of queries. Around the prioritisation matrix, it really seems to focus very much on projects and kind of external communication. I wondered how that matrix was going to be applied to ongoing daily communication with our staff. And the second, have you thought about looking at who our key influencers are and treating them differently so that I know it's possible now that you can do analytics on social media to really look at who are the influencers and who are they influencing within a system. And I was just a bit surprised that that wasn't there. There wasn't more about social media analysis and kind of using the power of that.
Okay, thank you for that. Do you want to come back on any of that, anybody, or are we okay and just absorbing that for when we come back in April with Simon's commitment at the April development session? Yeah, okay, thank you very much. And I'm assuming the 2 hands up are old hands now. Lovely, thank you very much. Keep going, Mark. Group People Plan Annual Review.
Thank you, Alan. And yes, just to pick up on one of those points, not to raise my hand again and bring it up and down again, but around the comms champions, Trevor, I think there's going to be a number of champions, as we'll hear at the end of April, that we could implement across the organisation, as long as we give people time to do it. I think that's the really critical thing. How do we give people time, given all the constraints that we have in situ? So I was going to talk a little bit around our people plan and our progress around our people plan this afternoon, if that's okay. As I say, I'm very mindful that so a number of colleagues have seen this presentation a couple of times, so but I'm mindful that some people haven't, so I will give it its fair airing, but mindful that we also want to move on to Emma and the volunteers presentation and indeed video. So welcome, Emma. If I can take the next slide, please, Kieran. Thank you, Kieran. So the people plan in terms of our 21 to 24, it was set around 7 pledges that we made literally almost 52 weeks to the day a year ago in terms of what our people plan intentions were and what the deliverables against those would be. They're all articulated in the plan. There was a set of measurements that we will have in place and we continue to discuss at our people committee whilst we develop our people performance pack. But there's also a new element to a metric that we have there, which was regards to our group people pulse survey. We implemented that in September, as colleagues will know. We undertook that once more in January, and we were about to undertake it again tomorrow. And this is really helpful because it really gives us trend information, which will then support the national staff survey positions around. That takes about 5 to 6 months to generate itself out to us. But what we would like to see is where we're making interventions or changes, what impacts are they having, and is it a positive one or negative? And equally, are we seeing any areas that are flagging as an issue for us that we can start to address at an early stages, as opposed to waiting a year for results to tell us that there's some issues there. And we know we can triangulate this with other information and data, which we've discussed at various meetings and forums over the last couple of months with regards to the age-old turnover, sickness, and so on and so forth, where some of them have been distorted because of the COVID situation. They are equally good indicators when you put all these together to say what's happening here. And as Alice referenced, we talked quite in detail about this at our CPC earlier this month, particularly in Kettering with regards to our healthcare support workers and our entry-level colleagues. we have seen over the last few months that there is definitely an impact there with regards to our ability to attract but also to retain colleagues in these roles. And we're taking that information from obviously talking to people, as Teresa said, the most traditional way of doing and communicating, but also through our pulse surveys and other metrics that we have that we're measuring our people plan against. Our final bullet point here was to fully implement our people plan across the group, and but therefore both hospitals, was to align our people services directorate, which we have commenced. And of course, testament to that is Emma here today, substantively now as our head of volunteer services, who operates across both Kettering and Northampton hospitals. And you will see in the video and showcase that Emma will put on later in terms of how we're really starting to take the positives and the benefits that we have in each hospital to make it a great service for both. Thank you, Kieran. If I could take the next slide. The next slide, which we have in our packs, it goes through the pledges. I won't go through these in any more detail, just to articulate once more that there are, of course, 7 of them, and they span across an employee's journey in the hospital. If I could take the next slide, please, Kieran. So achievements to date, I came back in September, as colleagues hopefully will remember, in terms of what we had done in the first 6 months around the people plan, which we also presented at the clinical conference. And I think it's fair to say, and it was acknowledged, that we'd spent the first 6 months working pretty hard with regards to health and wellbeing offering within the hospital, and also some improvements around our equality, diversity and inclusion agenda. We've obviously seen that through our board meetings in July. We've also seen it with various accreditations, as highlighted in Debbie's report with regards to our disability accreditation in the last month. This has been a real testament to the team and the strategy that we put in place, and we're really now starting to see the fruits of that develop. We also confirmed our plans to grow volunteer services, which Emma will talk about shortly, and our international nurse recruitment program specifically to help us support our vacancy rates. And you can see here in these 8 boxes some of the highlights around those in the last 6 months that we've been able to achieve. So we can see from our international recruitment program, we had a target of 200 colleagues that we would recruit from overseas into our hospitals, and that's been exceeded with 287, the last of which of the cohorts literally closes today on the 31st of March. So that's been really positive. We've learned many lessons through that journey, which obviously we've shared at various forums through colleagues over the past year, and we will continue to learn in terms of a retention for those colleagues too. I will pick out some others quickly here, but not to mention volunteers, because Emma will do that. But we also have worked collaboratively across our system on our health and wellbeing offering, and that led to a HSJ nominated project around our virtual health and wellbeing festival, which is a quick plug for me to say you'll see that again this year between the 4th and the 8th of July, which is a fantastic opportunity for us to showcase not just what's on offer, but how to support people from a preventative stage, if you like, of needing some of that health and wellbeing support and intervention that we've put in place. I think it's really important that we start to focus on the preventative now too, as well as the support that we've put in place to support colleagues, obviously. If I could take the next slide, please, Kieran. So this is a video that I'm not going to showcase here this afternoon. Colleagues have got the YouTube links here, and please do take it away and watch it. It's a fantastic video, and it showcases Val. You can see Val on our screen here. Val is a volunteer who is part of our Volunteer to Career program. Again, as Emma will discuss, one of our big initiatives around our volunteers is not just around the diversification and the increase in the numbers of volunteers, but how we help our volunteers see what we do as a hospital. Traditionally, as we know, hospitals are very much seen as clinical. Of course, there's clinical care that takes place, but doctors and nurses, and there's many other staff groups and roles in which people play in order to make that happen and to support those doctors and nurses to treat and care for our patients. And we have Val in this video, and also Josie, who's working closely with our schools in the local community to increase the diversification of our volunteers and help people in to have an opportunity to see what it's like to work in a healthcare environment, and then hopefully come forward and take a career with us, because that is one of the strengths that we have as a health service, I believe, in terms of supporting people's development throughout their career. I use my example. I started as a clinic assistant in a TB clinic in the Middlesex Hospital 18 years ago, and now I sit here in front of you today as a Chief People Officer across 2 hospitals. So that's the NHS has helped me in terms of developing into that particular position, and we need to showcase that for as many people as possible to attract and retain people in our workforce. If I could take the next slide, please, Kieran. Thank you. I think it's really important for me to come to the board and to other committees over this last month and to share our progress on our people plan, but also to talk about the context in which we've been operating in. Again, many colleagues will be aware of this. We've talked about it again during the course of today and previously. Just in September, which feels like a million years ago, we got the information that we had to commence the booster program across the county and within the hospital, which we absolutely did. We then all know well about the well-documented Omicron wave over the winter, particularly of December and January. And as Janet highlighted earlier, we're starting to see again now, or evidence of that obviously at the moment, but we're starting to see again during the course of March and April. And it's a real balance for us to make sure that we're able to support and mitigate our staff unavailability and absences to make sure we can provide safe and great care to all of our patients within Kettering Hospital. The last point here is around vaccination as a condition of deployment. It's only right and fair and proper I discuss this here. We talked about this in our meeting on the 31st of January. It's important, as you can see here, we've contacted a huge number of people as part of that process, and the legislation has been revoked in its entirety. That's not to suggest that it was not an emotive and difficult topic for people. How the team operated sensitively in those conversations is a real testament to us, I believe. We deployed our resources, of course, so we were distracted from other elements of progressing our plan, but it was really important, I think, and I feel, and I still do, that we handled this in the right way. 2,500 contacts were made with individuals, and not one of them led to any sort of formal issues in terms of those, how employees felt in terms of those conversations and how they were handled. And so that is real testament to the team, and there's been a huge amount of work in that. During the recent months, again, of course, we increased our staff support. We've increased provision of free food across the hospital as well for colleagues, and our people plan has been affected essentially. If you look at some of our metrics, which we discussed earlier around statutory and mandatory training and appraisals, and my point earlier around development, we haven't been able to progress that as we would have wanted with high unavailability of colleagues, and we now need to make sure we're able to be preventative to reduce our absence rates and continue to support colleagues. And one of the ways that we'll continue to support colleagues is by enabling them to undertake development and be able to move forward in their careers and feel really positive about the work that they undertake. During this time also, it's really important to point out that we worked with staff side to address some concerns around capacity, particularly as we move to transform and change how we operate and how we have more uniformity with regards to some of our processes and policies across the group model. We have done that, and we meet indeed in a couple of hours later this afternoon in our first meeting to address some of those situations, which I'll bring up on the next slide, if I could please, Karen. So one of the big the enablers here that we are discussing this afternoon with the view to approving this and being able to move forward is how we enable colleagues to work across the group model without additional, I don't know if bureaucracy is the right word coming from a HR person, but additional paperwork that needs to be completed and additional checks and so on and so forth. Of course, those checks are completed, but the duplication of some of this does not necessarily need to be in place. And we're looking to approve our MOU this afternoon, so we can have that in situ whereby colleagues can work across both sites without that additional paperwork required to make that movement much easier and transition with regards to collaboration across our services, both clinical and corporate services. We've established our joint working and forum, which I've talked about today. That's happening this afternoon. We also want to put in place our collaborative bank. We have a preferred methodology around doing this, which we have discussed. We have some issues here, which are real important issues that we need to discuss and tease out with regards to risks and mitigations one way or the other, particularly with regards to rates of pay. And there are many other aspects here that reflect back on our staff survey position that we need to undertake around reward, respect, recognition, and our benefits package. So that'll be the last thing that I'll finish on here in the bottom right-hand corner is what is the benefit of working in an NHS hospital, more specifically in Kettering General Hospital, and how do we accentuate that to colleagues given the constraints that we know people work within now and the cost of living increases and so on and so forth that we will see. So I haven't mentioned much around volunteers. I appreciate time is of the essence, so I'll move swiftly on to Emma, who will talk to us around our volunteers, and I'm happy to take any questions following that. Thank you.
Hi everyone, I'm Emma. I'm just waiting for Kieran to put the slides up, please. Okay, so I'm Emma Wimpress, and as Mark now mentioned, I'm now the Substantive Group Head of Volunteer Services. Can I have the next slide, please, Kieran? So as volunteers now forms part of the people plan, we have our own individual pledge, which is fantastic. So just to talk through our 3 top priorities, they are to standardise good practice across the group. So that's making sure our volunteers have the same opportunities, the same training and the same procedures. We're looking to develop consistency in our approach to volunteer utilisation. So that's to ensure that our patients get the best possible experience from our volunteers, as well as our non-clinical areas. And thirdly, it is to continue to grow volunteer services that is representative of our local community. Our patients represent our local community, and it's really important that our volunteers also do so. Next slide, please. So just a little bit about our Kettering volunteers. There's been significant growth over the last year, which we're really proud of as a service. So we currently have 216 active volunteers. And active, we mean by volunteering a minimum of 3 hours each week. On the main, lots of our volunteers do more than that, with some of them offering 1 or 2 days a week, which is fantastic. In addition to that, we have 35 volunteers in our recruitment process, and furthermore adverts out at the moment. There is an ongoing trial currently with volunteer recruitment that Northampton are leading the volunteer recruitment for all volunteers. It just ensures that they all have the same experience and we can align once they are fully recruited. Next slide, please, Kieran. So just some more about our volunteers. Again, there's been significant growth in our age demographics. I'm really proud to say that 19.3% of our volunteers are now aged between 16 and 19. And there has been a tremendous amount of work over the last 6 months with that. And again, 6.6 of them are between 20 to 29. Historically, on the main, a lot of our volunteers have been over 50. So we're working really hard with our local community to ensure that we're engaging with our future school leavers who are going to university, and we're continuing to do that. Now, in terms of the actual number of active volunteers, it does remain quite static, and that is because when we have the leavers who go to university or who are going to further education, we then have to backfill. So we know that with the relationships that we're forming with the local schools and colleges, we will always have that churn and be able to backfill those volunteers. But we're really proud that there is a significant shift in the age, which is fantastic for the future career pathway for volunteers. Next slide. Again, a piece of work that we're really proud of is historically volunteering has always been dominated by women, particularly in the NHS. So we're really proud that 1/4 of our volunteers identify as male, and we know this is something that we need to work to improve, but with it being 1/4, again, there's been significant growth in that, and we're really proud of it. Next slide, please, Kieran. So just to showcase some of the fantastic work that our volunteers do, we are looking to expand our roles, and we've done a tremendous piece of work in the last 6 months again to increase the roles available to our volunteers. And there's been a lot of growth in terms of increasing our numbers of volunteers in clinical areas, and they are supporting work, ward staff, being able to engage with patients, promote hydration, and continuing to support our pharmacy team by making sure our patients get their medication far quicker. The non-clinical roles is something that we're continuing to grow, and we're really pushing forward with areas such as the Care Cafe and the Brew Buddy service, which hopefully some of the staff are really enjoying whilst being out. So the Brew Buddy is a trolley that takes or goes out to all areas of the hospital, aiming for twice a week, and it offers all staff a hot drink. It's really, really well received by the staff, and it's a great initiative. So that's kind of just an overview of where we are. We're continuing to look at different areas, and we're working really closely with our patient experience teams to make sure that the volunteers are actually making a difference in not only supporting our patients, but also helping staff wellbeing. Now, there's no better way than to showcase the fantastic work of our volunteers than by video. So if I can have the next slide, please, Kieran, and ask you to take a couple of minutes to watch the video.
With their red shirts, it's easy to spot the volunteers from University Hospitals of Northamptonshire. Answering the phone is David, who wants to make sure everyone has a warm welcome and a great experience on site. In the office, coordinating everything is Josie. She's a key part of the team, making sure all roles are covered and that all departments' needs are met throughout the day. One of the most critical roles is pharmacy runner, making sure patients get their medication as soon as possible. The support the volunteers provide leaves clinical staff free to devote their time and attention to their duties on the wards. Pharmacy runners have an active shift, clocking up as many as 10,000 steps in 3 hours. The new Brew Buddy service is there for hospital staff. Volunteers visit clinical and non-clinical areas to offer staff a hot drink. It's been incredibly well received by all the teams. The aim is for Brew Buddy to visit them twice a week. The local community has been generous with their donations, and the volunteers love performing this role. The buggy service is there for visitors and outpatients to help them get around. Now it's easier to visit the hospital. The buggy is making around 30 journeys every day. It's part of the meet and greet service, which helps outpatients get to their appointment, then brings them back to their drop-off point. The service is appreciated by patients with anxiety and other mental health problems, making it easy for them to get the care they need. Another very active role is working on the response teams. Carol's shift is always varied, collecting swabs and bereaved notes, sitting with anxious patients, even delivering pizzas. This is another way in which the volunteers free up time for the clinical staff, so they can keep doing what they do best. Our ward buddies are there to support our patients, offering them companionship and even making sure relatives can stay in touch by helping them to make and receive video calls. Our hard-working volunteers make a huge difference to the lives of clinical staff and patients every day. They're at the heart of the hospital and our NHS.
Thanks, Kieran. If I can have the next slide, please. As it's been mentioned previously, promotion on social media is pivotal to our success. We have lots of donations from the local community, and not only just in time, but in things in supporting the Brew Buddy, donations to support different initiatives. So this just showcases some of the work we're doing on social media. And as Kettering Volunteer Services, we are continuing to look to increase our following and looking to sort of consider alternatives, but using the platform is something that really engages well with the community, and it's something that we're continuing to do so. Next slide, please. So what works well for Kettering Volunteer Services? So I just want to say thank you, as always, to the executive team for their support. They are real advocates for the volunteer services, and with their ongoing support and speaking about how well the volunteers are doing and engaging with us, it's really helping promote the service. As always, Northamptonshire Health Charity continue to support and are funding some of our posts, which is supporting the initiatives and supporting us to grow. And as I mentioned before, community engagement is pivotal to our success, not only in their donations, but engaging with us and putting posters up, advertising volunteers' positions for us, and continuing to work with us. MENCAP are one of the organisations that we're working with, as well as Job Centre Plus, and we're exploring different avenues, but that is really helping our success. Next slide, please. As always, there's always room for improvement, and we know over the last 6 to 12 months we've had significant growth. So what would help us improve? A designated volunteer area would really help for consistency for our volunteers, particularly as we continue to work with the likes of MENCAP, and we've seen an increase of volunteers with mental health issues coming to volunteer with us. It would really help, and we know from Northampton that this is pivotal to the success over there. Again, a larger team. We cannot grow the volunteer services team without the support to staff. But the reason why we're one of the leaders for the NHS in volunteer services is because we support our volunteers, we engage with them, and we make sure that the placements they're put in have ongoing support. And finally, we need to work with all levels of staff within the trust to raise our profile, to know that volunteers are there to support and will help their own wellbeing. So we take over the Care Cafe next week, which is phenomenal for us, a great movement, is it will allow us to engage more and more with staff. We'll be able to see more people more frequently. And I'm hoping that will help. We need to make sure we've got a higher presence as staff around the hospital, but I'm confident that with the team in place, we'll be able to do that. Okay, next slide, please, Karen. Here just shows some pictures that I thought is really important to do. We have in recent months brought the Pat Dogs back for staff wellbeing, which again has been really well received. And that picture there is of 2 volunteers who were undertaking their runner role supporting maternity. Now that was a really important day, the day we launched the runner role, as it freed up maternity staff to do jobs that they were doing best in caring for their patients, whilst the volunteers were able to support doing non-clinical items. And finally, what are our next steps? Sorry, next slide, please, Kieran. So as always, we will continue to work to increase our number of active volunteers. We know from patient experience feedback that the higher number of volunteers there are, the better the patient experience. We're going to continue to expand the response role to be more inclusive of clinical roles, because we know the impact on staff wellbeing is it frees up their time and allows them quite often to have a break, as opposed to quickly running down swabs to pathology. We will continue to seek external funding to support the growth of the team, because with this, we will be able to provide more volunteers that will help both staff and patients. As Mark mentioned, one of the things that we're really key to focus on is formalising our volunteer to career pathway. Not everyone joins us as a volunteer for university or college experience. Some of those are looking for a career change or just want to work for the NHS. So with recent successes of people gaining full-time employment, we'd like to formalise that. But most importantly, as always, we will continue to create roles that will enhance our patient experience and make a difference to their lives and their journey with us. Thank you. I'll ask if there's any questions.
Thank you very much, Emma. Very impressive recruitment exercise and new ideas and innovations. Any comments or at all on that, apart from applause? Polly.
Yeah, thank you very much, Chair, and thanks, Emma. So I just wanted to come back on the dedicated space point, actually, because Emma and I have had a couple of different discussions, haven't we, Emma? And also I just wanted to, first of all, say thank you for all the great work that she's been doing, and she invited me out on the Brew Buddy experience going around some of our wards, which was a really, really good experience. Great to start talking to some of our volunteers, but also say thank you to some of our staff. So on the dedicated space, totally recognise that we need to do that. Our new ways of working pilot that we've been rolling out across the trust and we've now had in place for 4 weeks has started to identify where we do have space that is currently underutilised by some of our corporate and office staff. So watch this space, Emma. I'll be coming back to you. I think we need to probably run the pilot for another few weeks just to make sure that everybody is using it properly. And I'm fairly confident, actually, and we spoke about that at our senior leadership team this week. I'm fairly confident we're going to be able to find some dedicated space quite shortly. Thank you.
Okay, thank you very much. Nothing else. Congratulations, Emma. Good stuff. Lots more volunteers to recruit. Excellent. And if non-execs sometimes wonder what the best way is to visit the hospital, well, the Brew Buddy thing seems to be quite a successful way to do it. Right, thank you very much. Mara, I see Mara is with us.
Good afternoon.
Your title was corrected for me yesterday, Mara. Now Deputy Director of Midwifery at NGH, as well as something similar at KGH. Right. So anyway, take us through the Ockenden review and where we are. But please remember, as I said to everybody, we looked at this on Ockenden 1, and it will be coming back to the May board in both hospitals as an exercise in how do we know our maternity services are safe. Mara, over to you.
Thank you, Alan. So yes, I'm Mara Tonks. I'm the Deputy Director of Midwifery here at KGH. So I'm here to update you on our progress against the actions that were required from maternity services from the interim Ockenden report. So we're just over 1 year on from that report. So in terms of overview, I'm sure you don't need to be reminded because many of you will have seen the national news yesterday, but the Ockenden report is an independent inquiry into the concerns surrounding maternity services at Telford and Shrewsbury Trust. The inquiry set out to investigate the concerns initially of 23 families, however, has grown to include more than 1,500 families. We know that the final report was published yesterday, and the report itself in details a further 60 plus local recommendations and actions for Telford and Shrewsbury, but 15 further immediate and essential actions for all maternity services in England. However, in 2020, an interim report was published based on the findings of the first 250 families. The interim report made 7 immediate and essential safety actions for maternity services to implement. So maternity services at trust level, but also through maternity, local and neonatal systems, went through initial assessment in 2021 to evidence their own compliance in relation to the 7 immediate and essential safety actions. In Northamptonshire, we had no areas of non-compliance, and at Kettering, the initial assessment demonstrated an overall compliance of 80%, with the remaining 20% being noted as partially compliant. The assessment process was overseen by our regional perinatal teams. And in January this year, all maternity services were written to by the Chief Nursing Officer and the Chief Operating Officer for NHS England to ensure that a further local discussion is held at board, which takes into consideration our current position of compliance in relation to the first interim Ockenden report. So why I'm here today. Boards were also asked to reconsider their progress in compliance in relation to the Morecambe Bay Kirkup recommendations from 2015. So as well as this paper today and the appendices that you'll see from this paper, we also prepared a separate paper that was considered by our Joint People Committee earlier this week, which demonstrated our compliance in relation to the workforce elements that the interim Ockenden report issued. At the Joint People Committee, I also updated all members of our current staffing position as an organisation and the actions and mitigations that we have taken to address our vacancy and felt unavailability rates currently, but also noting that this is not unique to Northamptonshire or KGH, but obviously facing the whole of maternity services in relation to the national shortage of midwives. So you'll see from the attached paper and appendices that we have made significant progress as an organisation at KGH, and we have implemented all 7 immediate and essential actions from the first Ockenden interim report. And as Alan said, we will now be preparing a paper to come back in May to provide assurance around the further 15 recommendations that were made yesterday. I'll pause there.
Good, excellent, thank you very much. Any comments on that bit of what Mara's going to say? Rabia and Lisa. Rabia, you're muted.
Sorry, do sit here with quite a heavy heart because I did skim read 250 pages of what was published last night. Yeah, the case studies of it, it's really, really sad. And I think particularly for me, because it is my own area of clinical expertise, so I'd really understand it well, that some of the stuff was basic, very, very basic. So the thing for us here is absolutely we need to come back to say that we can provide assurance on maternity services are safe. But one of the things in the new report, or in the full report, which highlights completely, is around governance and learning. And I was reflecting on it, and I think what we will be definitely doing is extending it not just to maternity service, but the level of investigations that are carried out per se, or the governance processes, and making sure that learning is embedded throughout, beyond maternity as well. So I'll be working with Mara and Fiona and the maternity team. But in addition to that, I think we'll be looking at our governance processes with regards to what is highlighted in the full report.
Lisa.
Yeah, just as the maternity lead from the board, just to support Mara and the team, we've got an incredibly strong leadership team in the midwifery and obstetrics service. As the maternity safety champion meeting, we regularly see all of the data around SIs, which then goes up to quality. So if I look at Ockenden and the lessons around failure to look at the data and understand what was going on as a board, we are doing that. We look at that data regularly. Failure to address patient concerns. Actually, this team has reached out, and even during COVID, had virtual meetings with mums and to-be and mums that have had children. So I'm assured that we are listening to our patients. And in terms of support for parents who've lost children, actually, I've met our bereavement midwives and they are superb. And they really reach out, and we've had really positive feedback from, sadly, those families who've had that unfortunate incident, and they feel really supported. So I look forward actually in May to really supporting Mara in looking at the Ockenden too, because I have full confidence that some of those things that have been highlighted, like reducing continuity of carer while there are midwifery shortages, actually Mara and the team implemented that without the need for national guidance. So I feel confident that in May we will be in a really strong position.
Okay, thank you. Trevor?
Thank you, Mara. I think having heard the People's Committee presentation earlier in the week, I think one of the things that for me was strong was the preemptive training of new midwives. And I think to compliment the team on that sort of foresight, and you want to say, well, why hadn't everybody else done it? Well, we've done it. We've got to make sure that all those new potential midwives of the future come through to KGH as we've got them at the moment. But thank you for doing that piece of work. And I think it deals with some of the problems now, but it's going to be forever a challenge, we know. But thank you for doing that piece a couple of years back.
Okay, thank you. Finally, Simon.
Thanks to Mara for all her leadership in this space, and also for our maternity champion at board, Lisa, for all your scrutiny of this work. It's incredibly important. I think just to link with the conversation that we had yesterday, 2 additional points. Mara, you, I know, made the point yesterday about we're in a relatively fortunate position from a student point of view coming through, so you may wish to just assure the board that we have a strong pipeline in place, which I think is helpful for our resilience. I too have skim read a fair chunk of the report, and I would suggest that it's required reading for all board members. And I think the other thing that came out in yesterday's discussion, which I would want to amplify and reflect here, was I think an important feature of our May discussion should be hearing patient voices as much as is possible in that discussion, linking to some of the things that we have talked about today. And I think compliance is one thing, and I am not complacent about that, but the lived experience of patients as they go through this service, I think, will be an essential feature of our May report.
Thank you, Simon. I'll take that opportunity, if I may now, Alan. So in relation to what we have done before, so absolutely, we undertook a piece of workforce analysis going back just over 2 years ago in Northamptonshire, recognising that we had an ageing population of midwives. So we were going to have more midwives retiring in the next 5 years as what we were going to have midwives qualifying. So at that point, we did a piece of work with the University of Northampton, but also Health Educational England, who were incredibly supportive at the time, to increase our student numbers in Northamptonshire by 100%. So next year we will see the fortune of that, because those midwives have been in training for the last 3 years and they will qualify next year. So we'll have double the amount of students qualifying in the county to what we have previously. We're also doing a brilliant piece of work over at NGH, but still within this system, around the international return to practice midwives. We've welcomed our first midwife from Jamaica at NGH this week or last week, and we'll be welcoming a total total of 9 international return to midwifery practice midwives, and that's absolutely something we could look at emulating over at Kettering, or supporting those midwives with actually joint placements across the organisations. And we are also utilising registered nurses within the service as well, both at KGH and NGH, where to mitigate some of our staffing shortfalls. One other piece of work that I just want to emphasise on is I'm going to be writing out to all recently retired midwives that have retired from both services in the last 6 to 12 months, to try and entice them to come back and work in a supernumerary capacity alongside our new starters, recognising that yes, we are going to have additional workforce, but we're going to have an additional junior workforce. So in order to give them that psychological safety and support that they need, I will be asking our retired midwives to come back in a supernumerary capacity, and we've already seen appetite for that at Kettering.
Okay, it's really good, Mara, and we absolutely have confidence in the leadership team here. Doesn't mean we don't have to prove it to our public, and the May event will be important, and the patient involvement, that will be important. I look forward to you working your magic in Northampton over the next few months, and then going forward from there. Thank you very much for a very concise report. Thank you. Right. We don't have any questions from the public, do we? Somebody? Richard? No? Good, thank you very much. Any other business? Anybody have any other business? No? Well, the any other business is Janet, really, isn't it? I mean, 7.5 years, Janet. It's, people get less than that for serious crime. And you have stuck the course. There's lots of reasons why non-exec directors leave, not always of their own volition, it has to be said, but you have stayed the course, and you are easily the longest serving Ned here on the board, even before Trevor. That's quite something. The important point to think about things is, look, you made a difference, and you will be missed. Those are the 2 most important things you can say about anybody when they leave something. I've asked the governors to approve an advert for your replacement, and the advert is such a vivid description of you. I gave serious thought to putting a photograph of you in the advert, so we just want another one of these. But in fact, we are looking as much as possible for another Janet. I know that's going to be hard to find, but that's the clearest indication too of how we valued what you've done. So I'm sorry we're not all together. There is, as you surely expect, a card and all sorts of other things around, which we will find an occasion to do. But you have our very best wishes. We look forward to seeing you work your effects on the ICB, where you have even fewer colleagues to shine amongst, with only another 3 non-execs apart from you. But I look forward to continuing to see you there and helping in any way we can to help you do that job and stay connected to us here. So thank you very, very much, Janet, and the very best of good luck in the new role. Thank you.
Thanks, Alan, and thank you to the staff, governors and all board colleagues for an amazing experience working at Kettering, and good luck for the future. Thank you.
Thank you very much. Okay, we have overrun. I'm terribly sorry. I blame the agenda planners, not the chairman, but that's just the way it is. I'm going to give you an extra 5 minutes. Can we make it 2:05 back, please, for the private board meeting? And I know Simon's not there, so we'll be taking it without Simon. Thank you very much, everybody, for your contribution this morning. Good meeting. 2:05.